Sound check 1 2.
Hello, hello, mic test. Hello, hello, mic test. 1, 2, 3. Hello, mic test. 1, 2, 3. Mic test. Hello, mic test. 1, 2, 3, 4. Mic test.
Sound check, 1, 2. Sound check, check.
طيب السلام عليكم جميعا. We start our session inshallah today, which talk about clinical practice guidelines. سيبدو لي الحضور يمكن اللي حاضرين في القاعة بس يمكن only 11 person 11 بس. We start first lecture with Dr. Jassim. He will talk about clinical practice guidelines development. Dr. Jassim is consultant in neonatal ICU, fellow of Royal College of Physicians and Child Health UK, Saudi Board of Pediatrics, fellowship in perinatal and neonatal medicine, assistant professor of pediatrics, King Saud University, Riyadh, Saudi Arabia. Dr. Jassim.
Okay, Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Abdurrahman. Thank you, organizing committee, scientific committee, for inviting me today to talk about this very important topic and efforts we have done in the Saudi Neonatology Society about the clinical practice guidelines and the project to make it like national project to improve and to collaborate between health sectors and make it like national evidence-based clinical practice guidelines for neonatal healthcare in Saudi Arabia. It is a collaborative approach and guideline between health sectors in Saudi Arabia. As a clinical practice guideline, I think everyone in practice of neonatal medicine knows how important is the presence of unified clinical practice guideline. One of the important things that make best evidence-based decision and patient in time efficient manner. So if we have a guideline in each center, we have to obey and follow that guideline, which make us like we talk in same language. Not one baby will be managed in a way today, and with other physician it will be a different, or in health sector will be in a way, and another health sector managed in different ways. So it will make like best evidence based on the criteria of that situation in that country. Is not like we just imported from different guidelines. Also, it help in reduction of practice discrepancy, release the tension between the healthcare cost and quality. Because if you do everything, for example, in neonatal sepsis, you can do everything for every baby. But with the evidence-based clinical practice guideline, we can use our resources with the best available evidence to save our babies. Initially, we considered in Saudi Neonatology Society a lot of objectives. We have 7 objectives since the started of the society a long time ago. And we read in between that our objective to draw out a recommendation for neonatal care at different levels. From that objective, we make a strategic plan and we try to look into how to improve and how to do that objective on the real time and on the ground. This is at one time, it was the organization chart of the society. And in the scientific committee, we consider all these committees, they were belong to the scientific committee. Then we look into how to improve. We implement a lot of, this is the conference, annual conference, the committee for research, already talked to Dr. Sajjad yesterday, the Journal of Clinical Neonatology, father of that journal, Prof. Saidi, then clinical practice guidelines. So we make a committee for practice guideline to improve the objective of Saudi Neonatal Society. Then we plan how to proceed with the clinical practice guideline. We have a very long preparatory phase. Initially, we selected the topics which needed mostly by the healthcare community. We don't like just to start any topic. We make a long selection between topics, what we needed in Saudi Arabia, more priority than others. highly skilled team were involved in different CBGs. Workshop introduce team to each other and work scheme. We did maybe 3 or 4 workshops to train people on the clinical practice guidelines adoption system and how to proceed. Then we create small working groups to address different topic at different times. Then we start the journey. During the team creation and selection, we try to use multidisciplinary teams. So we choose from neonatology, methodologists. Dr. Yasser is not with us today, but methodologists play a very major role with us to adapt and adopt our clinical practice guideline. Nursing, they were part of us. Other related specialty like in pediatric infectious disease, in sepsis, ophthalmology in case of ROB and other specialty. Clinical pharmacists also, they were involved, and community representative were planning to involve, but unfortunately we couldn't find very suitable representative, but it was planned initially. Even we use from different health sectors to make easy implementation and to hear from different health sectors. So we choose from Ministry of Health team, Ministry of Education, National Guard, military, armed forces, and private sector also we choose. So it will reflect on all health sector in Saudi Arabia, and we try to modify the guideline according to different situation. Then we select 5 clinical practice guidelines. All of them reach to the stage 7, which is the approval stage, except one enteral feeding for preterm infants, because after this details, rigorous search, we couldn't find published clinical practice guidelines, so we cannot adopt any guideline for enteral feeding of preterm infant. Although the Saudi Neonatology Society started a consistency-based clinical practice guideline. That one we will go for 2023 for de novo adaptation or de novo creation of CBG. The other 4 HIE, which is very important and very highly demanded with a lot of controversies: retinopathy, prematurity, neonatal sepsis with the help of pediatric ID, normal newborn infants, and we summarize in normal newborn infant a lot of routine care at birth, and Dr. Amal Zubani will talk after me about this clinical practice guideline. Then we registered our protocol of practice guideline in international society, international BRUS Bureau, we call it BRUS Bureau, International Prospective Register of the Systematic Review. So it is internationally recognized even before we start, and they approve our methodology and our result. Why we choose evidence-based? Because we have 2 types of clinical practice guideline. Either we talk about evidence-based guidelines, which is very detailed discussion about the methodology, or we talk about consensus expert-based clinical practice guideline. I don't like to go into more details of methodology, but we have 4 phases. Setup phase, we will select the topic, we study the feasibility of the guideline and team formation, adaptation, and then we have a plan. Then the adaptation will start with the health question, VIVOs, and eligibility criteria. We make a very detailed search. We use Librania for that one. And Ms. Layal was very good help for us, but she gave us very long, a lot of citation, 22,000 and so forth. So we spent very long time to select that citation. Then we use the agree to instrument to assess the quality of that guideline, to choose which guideline is suitable more for us and with evidence base. Finalization of phase with external review, and we will go into the other 2 phases shortly. This is how it's look like Prisma chart when we make the clinical practice guideline and we criticize and we see the citation. For example, we have this is Prisma chart for the neonatal sepsis, and we have very rigorous, we use for midline, MPACE, senile, and Web of Science, a lot of even meta-analysis, and we search the index of articles. Then we end up with 6 only citation. Then after that, we review it and we make our conclusion about the clinical practice guideline. This is how we extract the data. We find this is the management of neonatal sepsis. We have 5 guidelines, or actually it is 4, but one is divided into 2 parts. But we put it into the recommendation matrix. Then we compare all the recommendation together. Dr. Rana Al-Maghribi, I think she will talk about neonatal sepsis and how the guideline help us into improving the adaptation process. This is how look like the assessment tool of the HIE CBG. So we use agree to see we have 2. I think it's working. No. Enter. So this is the Canadian, and this is the Queensland, and how we assess different domains. So the scope of purpose, how the clinical practice guideline assess their scope, determine the scope and the purpose, the stakeholder involvement stated or not, how rigorous for the development. See all of the 2 international guidelines, they have a very low percentage of rigorous development. At the end, we have we use the overall assessment, which is for Canadian 63, for example, in this Canadian guideline for the HIE, 63% and 83% for Queensland. Overall assessment, we have 4 team members use, and 2 of them, for example, said yes, we can adapt it. 2, they need some modification, and 0 assess. So we have 4 different assessments at each guideline. So this is, after that, we adopt this, for example, guideline. This is for sepsis. And then how it look like the guideline later. I will not go into details. You will see it after approval, and maybe our colleagues, they will present some of it. So it is very detailed what we will do for timing, for example, of antibiotic or what investigation and so forth. How this is how it look like for final. There is some diagrams and help into that guideline after approval. It will be very helpful, and there is a lot of summaries and algorithm with tables like this. Risk factors, indicators, we put it into very handy illustrative tables. This is algorithm, baby on antibiotic treatment for suspected infection. For example, we adopt this algorithm. Now, after we do this very long journey, it took around 7 to 8 months. We sent for very unique and international recognized reviewers. Dr. Hani Ali, chairman in the Department of Neonatology in Cleveland Clinic Children's Hospital.
1 minute.
Okay. Professor of Pediatric, and Professor Ivan, Associated Professor from Columbia and from Hamilton Canada McMaster. Then we translated into layperson translation, and we send final version for approval of international or national organization. So in summary, we make protocols. We register in Prospero, international organization. Rigorous search with very detailed citations, selection of citation, evaluation of citation, adapting of the clinical practice guideline. Then we send it for external reviewers, international CBG registration, and then we send for approval. This is first publication. We published the appraisal guideline of systematic review of neonatal guidelines and for TNEs in pediatrics. Those work, it will not be finished with 1 man or 2 men. We have a very long and very huge team. And I would like to thank all the team who participate with us. In HIE, we have Afnam from pharmacy, Aisha from nursing, Dr. Ayman, a neonatologist, Abdullah Al-Anizi, neonatologist, Ibrahim Al-Hifdi, our senior consultant neonatology, Yasser from obstetric, perinatology, Asma, neonatology, Ahmed Al-Ayubi, obstetric, Muhammad Abdul Mawla, neonatologist, and we have Dr. Umar, team leader, Dr. Yasser Layal, and myself. Retinopathy prematurity with Dr. Abdul Hakim Gattan, neonatologist, Imad, neonatologist, Hissa, clinical pharmacist, Latif Al-Mahmoud, neonatologist, Dr. Mansour Al-Qurashi, consultant, Syrian consultant neonatologist, Professor Ahmed from nursing, Dr. Sameh, consultant neonatologist, KFMC, Salih Al-Amro, he is ophthalmologist and he's senior ophthalmologist, Dr. Abdul Razak from Princess Noura, Yasser Layal, and myself. This is constant names. Enteral feeding, this is the team, but unfortunately we couldn't finalize it because the reason I mentioned. But Dr. Fahad Al-Aql, Fahad Al-Harbi, Professor Ahmed from nursing, Abdurrahman Zahrani, Rafat Musalli, Yasser Layal, and myself. Neonatal sepsis, Dr. Adnan Hadid from King Saud University, Amir Al-Darwish, clinical pharmacist, Badi, obstetrician, Ahmed, professor of nursing, Abdurrahman Al-Nimri, our president of Saudi Neonatal Society, Dr. Rana Al-Maghribi, consultant pediatric ID, Abdurrahman Al-Mihiri, our senior neonatologist, Nawaf Al-Dajani, team leader, and ourselves. Normal newborn, Al-Anud, clinical pharmacist, Ali Mudir, senior consultant neonatologist, Aisha, nursing, Heidi, neonatologist. So if you can see, Muhammad Al-Hindi, Saad Al-Saidi, Khalid Al-Kawi, it's different specialty. Amal Zubani is the team leader and she will present the next talk. Yasser Layal and myself, you can see that they are in different specialty and they help us a lot into how we can implement and tailor the two team. Thanks to all teams, a board of directors from SNS, Saudi Health Council, Saudi Society for Health Specialty, MOH, and our team. Thank you.
Bismillah, assalamu alaikum. Our next topic, inshallah, will be the topic of normal newborn care. Will be presented by Dr. Amal Zubani. Dr. Amal Zubani, she is a consultant neonatologist. She's head of section in King Faisal Specialist Hospital and Research Center in Jeddah. Dr. Amal, welcome, please. Thank you.
Thank you so much. Assalamu alaikum. يعطيكم العافية جميعا. First of all, I would like to thank Society for their invitations to be one of their distinguished speakers. At the same time, I would like to thank them again, including Jassim and Dr. Yasser, of course, Al-Prof Nimri, for giving me the opportunity to share one of these clinical practice guidelines. And of course, my special thanks to the team, which is I work with them, despite that our busy schedule. But Alhamdulillah Rabbil Alameen, we are able to proceed for the things, inshallah. So basically, it will be the routine care for neonate and newborn. And as you see, it's already registered SMS CBG 03-01. I don't have anything to disclose. And always, this is the first picture I actually borrowed from Prof. Nimri, that every time actually we comes and we think that we're going to teach, we're going to give few points, we discover ourselves actually learning. And the best thing when we learn, that's mean we will grow 100%. So it's mirrored to each of other. So as an introductions, and I would like to say that this is actually taken from the paper Tamam itself, which is we are already, inshallah, going to publish it very soon, inshallah, that after birth, most of the full-term infants and the early-term infants require normal neonatal care to make a successful transitions to the extrauterine life. The most important things as well, that the major component of the routine care include delivery room and transitional care, including the early bonding and newborn assessment, including a comprehensive comprehensive review of maternal history and a complete physical exams. So our recommendation went through were adapted from 5 main sources of the clinical practice guidelines. This include is NICE, which is the Neonatal Institute for Health Care Excellence, and the Royal College, which is basically both of them in UK. We have the United States Preventive Task Force, and we have the Canadian Cardiology Society and the association as well. And we have the European roundtable meetings as well. And of course, using a normal methodology, which is from the KSU and modified as well. So what exactly our target? Our target population is the normal newborn. The intervention and the practice consider is routine care after delivery. Of course, we have the people with the stakeholders, which is from everywhere: physician, nurses, pharmacists, laboratory, and all this. And the most important things is actually the outcome. What's the major thing we need to know about that? So infant health, which is basically include the physical examination, serious illness, bed sharing, of course, breastfeeding, because we have been talking about that in the last few days, and emotional well-being and bonding with the baby. And of course, the health setting, it's all the primary, tertiary, secondary, and tertiary care center across the country. I would like to say for the quality of evidence, because again, this is very important. We know that from institution to institution, from association to association, we know there is different definition of the evidence. Some of them use the word of must, could be, maybe. Some of them use A, B, C, D, and some of them, they are using high quality, low quality, and moderate quality. For the purpose of our evidence for this clinical practice guidelines, we look into the evidence with high quality, and we define what exactly we are looking for: the high quality, the moderate quality, the low quality. In the same times, we look into the recommendations, and we defined what exactly the recommendation we look for, which is the strong and the weak. But I would like to mention is a very important as well when it comes to the quality of evidence and the recommendation. It comes to the patient themselves. That means the patient has the right as well to be selected and to be one of those categories and to be involved in these clinical practice guidelines. Even the physicians, when we come to the physicians, the recommendation that the physician has to use their knowledge, their practice, and the evidence-based medicine in order to practice the right care for those normal newborn, not only to depend on his experiences and in his practice. And again, and this is the most important, and this is the message for the stakeholder, which is basically the policy makers. They need to know 100%. They have to set a policy, they have to set a guidelines, and the most important part of that, they have to do the quality improvement on it to ensure whatever they are delivering is the optimal care for those specific patients. So as a key recommendations from the paper, we came with the management of postnatal care, which is basically include the assessment and care of the babies. Simply, that means the baby is feeding, urinating, pooping, and we look into the most important one, which is, again, we didn't find a guidelines for it, but we included it, which is the hearing, the jaundice, and in the same times the metabolic screen for them. We look into the bed sharing, and we really indicated for those what the things they need. They need to be sleeping, for example, in a firm mattress rather than they will not sleep in the sofa. The family or the parent, they will not share if they are a smoker or in any medication can cause drowsiness. So this is, again, is very important. Promoting the emotional attachment. And when we talk about the emotional attachment, we look into the interaction between the parents and their babies, which is basically face-to-face, skin-to-skin, and all that. Symptoms and sign of illness in babies, and planning and supporting babies feeding, which is, again, very important. This is adapted from NICE from 2020. When it comes to the ocular prophylaxis for the gonococcal, again, the only message which is I would like to highlight it here is a mandatory and the standard of care. This is no questions, no doubt about it. And this is again from the US guidelines. The other thing which is very important, which is I will not spend time because my colleagues, mashallah, tabarakallah, Ali al-Mudir mentioned it the other day when they talked about a critical congenital heart disease, but we emphasize it in our guidelines that it has to be done between 24 up to 36 hours. It has to be in the right hand and either foot. And normal newborn, whenever you have abnormal result, you have to go to the next step, which is repeat. And then if we have an issue with the repeat, you have to go right now to echo and the cardiologist to be involved. When it's come to the umbilical cord care in the newborn infant, remember that application select antimicrobial agent to the umbilical cord does not provide a clear benefit in the hospital setting or a high resources countries. In fact, reducing the bacterial colonization may have unintended consequences for selecting more virulent bacterial infections. So just general statement, keep it dry, take care of it. Make sure that you are not doing anything, don't make it wet and all that. And this is again adapted from American Academy of Pediatrics. Also in our paper, we mention more details, and my colleague Selma from nursing yesterday did an excellent workshop about it. In fact, they they asked us actually to do it more frequent about skin care. We included everything when it comes to the skin care, the first cleansing. We also would discuss a routine bathing, when exactly the best time to bath those babies, what's the safety we need to take it while we are taking all of that, the liquid cleanser for bathing as well, and how you will care about the diaper rash and the use of oils and the other things, which is very important. Very, very important when it comes to the clinical pathways, because remember guys, the aim of the pathway is actually to improve the quality of care, and in fact is reduce the variation. And this is the most important things. When we reduce the variation, that means we are going for a standard of care as well. Amal Dubani is not different than Jassim. And if that variation happen, why it's happened, why it's okay, and this is the reason behind it, is comes to the most important part of the clinical pathway, which is maximize the outcome of those specific age groups. So our age group in this clinical practice guidelines is the normal newborn. And again, this is adapted from NICE when they look during the COVID era, which is basically you are taking care of the baby and in the same time you are taking care of the mother. What the things you will look into that, and in the same times, while planning and supporting for the feedings as well, how important after the delivery is just to give huge information to the mother, to support the mother and to support the babies as well. So basically you are taking care of the baby and the mother in the same time. And again, this is the first one, which is, I mentioned it earlier, when it comes to the assessment of care, the bed sharing, the symptoms, and we link also from where we get those adaptation as well. Again, the pathway for the critical congenital heart disease is very important, and all of us, most of us knows about this one. So we put it in our clinical practice guidelines, because again, you want that peripheral hospital as well to understand what the things to worry about, what the things they look into that. And we even include for them what's the critical congenital heart disease lesions, and in the same times what it could be a heart lesion which is require an immediate interventions in order to help those physicians and those caregivers where to detect the problem. Okay, there. This is again what exactly written. So whatever you would like to have, you have to have the permission from SNS, and I'm sure they will send it to you guys. I will not mention about, because Jassim already, mashallah, tabarakallah, mentioned all our colleagues, but really I would like to thank Jassim and Dr. Yasser, because they were so patient, in fact, with us when we go through that. Already Jassim touched what's the inclusion and the exclusion criteria. This is exactly how many of the years of publications and which guidelines we went to, and that exactly what the index mentioned by Jassim as well. If you see, you will see NICE and the Royal College, in fact, touch typically what we are looking for it for normal newborn. And this is again the steps which is mentioned by Jassim as well. And as you see, alhamdulillah rabbil alameen, we did very good job on the selecting most of the things. And if we didn't selected it, we will put why we didn't select these guidelines, okay, here. So the question is right now will be, where are we right now? So the goal, the first goal actually is to publish this one in the systemic review of guidelines, because by publish this one like Al-Arubi, we don't need the permissions here. But the second goal, which is the most important, is actually the goal when we take the permission. So we send this to the Saudi Health Council, and as you see that they are accepted the clinical practice guidelines, but they sent for us some of the modification we need to do, and in the same times they will look into what's further step to do. And we already get some of the permission, because remember, copyright for all the guidelines which we adapted our pathways from it, we have to take the permission. So already we get 1 and 3 actually to go. Once we do all this, it will come the most important part of our publications, which is to be an open access. It should be access to everybody. It should be in our recognized journal. And from there, it will be national for our clinical practice guidelines for the Saudi, inshallah, bi'idhnillah. And you never know, maybe one day will be also international as well. So this is a summary of the clinical practice guidelines for newborns. So thank you so much. Thank you.
Thank you, Doctor, for this nice lecture. Next lecture will be presented by Dr. Rana Al-Maghribi. Dr. Rana, consultant of pediatric infectious disease. She's pediatric antimicrobial stewardship program head. She's the president of Pediatric Infectious Disease Society in Riyadh. Doctora will talk about neonatal sepsis.
Bismillahirrahmanirrahim. Thank you for the introduction, and thank you for the organizing committee for inviting me. But actually, I don't know if safe to talk about neonatal sepsis in front of more than 100 audience of neonatology. I don't know if it is safe or not, but I hope my husband, he's neonatologist, so maybe he will protect me. In this lecture, I will touch on 3 important points in neonatal sepsis. I know we are still struggling in defining neonatal sepsis in comparison for defining sepsis in adult or older children or teenager. The second point I want to really stress on it, what is the theory of the serum biomarker, and what we have now for the diagnosis of neonatal sepsis and what is coming. From there, I will talk about our guideline with the collaborative with the CNS Society. Actually, over the last 10 years, there is huge advance has been made it in neonatal sepsis in form of epidemiology, pathophysiology, diagnosis, monitoring, and treatment. And as you know, originally, sepsis or neonatal sepsis came or derived from Greek word, which is SIBO, which means eye rot. And definition of neonatal sepsis or sepsis in general continues to be evolving in 21st century, and it was established in adult in 2016. But still, the concept of sepsis in neonate has proven difficult to be defined, and it is really challenging. A lot of publication and a lot of physicians, they try to find the challenging in defining neonatal sepsis and how we can manage to establish the definition for that. But till now, we don't have a really clear or exact neonatal sepsis definition. But generally, what we will use, or what we use to as accepting criteria for neonatal sepsis, are organ dysfunction in setting of infection, depending on the infection in the sterile site, either blood, urine, and the CSF. But sometimes in the critical area like PICU or NICU, even if non-sterile site, with some abnormality like apnea, brady, or a tachycardia, we refer it as a sepsis. With aid of some biomarker, we send for CBC, CRB, all this biomarker, we use it to help us to identify or guide us in neonatal sepsis. Although we lack really of reliability of this marker. We'll go to the blood culture. You know, the blood culture, it is really wonderfully sensitive and extremely sensitive. If we take the blood culture by proper way and we take the proper amount of volume of the blood, like from 0.5 to 1 ml, and this is, I think, the minimum recommendation by American and Canadian guideline. Dr. Shugalanda, he published this paper in Journal of Pediatrics. What they found, if we take 1 ml of blood culture, it will determine even if there is low level of bacteria. If we have 5, 10, 100, we'll reach to the sensitivity of 100%. But the problem in the NICU, really, a lot of things like sepsis. There is Dr. Dempsey here in Journal of NEONATOLOgy in 2006. They mentioned apnea, respiratory distress, and hypotension are 10 times or sometimes 100 times more common than sepsis. Not only that, also respiratory distress syndrome, transient tachypnea of newborn and atelectasis is more than sepsis. Not only it is over diagnosis, but also there is like complication and poor outcome. We know it is a neonatal sepsis, carry high mortality, morbidity in the NICU, but not only that. Dr. Schurman in 2019, before pandemic, he published, this is very nice, actually, retrospective, cross-section and a study in California, California Perinatal Collaborative. He took 326,000 live births, over 120 nurses. They found the median number of antibiotic courses per early onset sepsis is 95. And when we see the number of antibiotic courses per late onset sepsis, it is really 19. So what they found and what they conclude, the number or the percent of newborn receiving antibiotic for neonatal sepsis is not correlated to the proven either early or late neonatal sepsis. We agree with you as ID. It is really challenging diagnosis, difficult or hard to distinguish infected baby from non-infected. But we believe there is the non-infectious condition may be more common than sepsis. But I want to remind you about the Spartak's character when they want to catch him and they don't know who are, so they kill them all. So this is what happened exactly. If we cannot distinguish sepsis patient from non-sepsis patient, we will treat them all. And here from Dr. John in last year, he put ideal biomarker. It could be help us in diagnosis or guide us in neonatal sepsis. So in general, we have to have like well-defined cutoff level of these biomarker. It has carry high or positive negative predictive value of 100% high sensitivity, and we have to have like biomarker help to identify the neonatal sepsis before it happens. And you know, we are dealing with neonate, so we have to have biomarker need low blood volume and fast turnaround time. For sure, we need low cost and widely available. But currently, actually, we don't have this test to fulfill all these criteria. So what we have now? We have the CBC, and this is very old and original test we ask for any patient with the suspicion of sepsis. Here, this paper maybe 50 years back, they mention about the facularization or toxic granulation in the neutrophil if it is found, so it will help to diagnosis of neonatal sepsis. But I don't know if this can help us in ICU. So there is two study. Really, it is very clear for us. Maybe it will not help the facularization of the neutrophil in diagnosis of neonatal sepsis. Sorry, I need. Okay, here when we talk about absolute total neutrophil, we found the specificity for it 51, although we have high negative predictive value of 99. But when we compare this one to the immature, the total neutrophil count, we will see it carry really high specificity and high neutrophil negative predictive value. So this might be helpful in diagnosis of neonatal sepsis. In comparison to this is another study, and it is retrospective study done in 166,000 infants with suspected early onset sepsis over 293 different in ICU, and they took different value of the CBC. The majority of the infant with the early onset sepsis had normal CBC. So really we have to look on it again. When we see to the CRB, I think most of us, we ask for CRB in the neonatal sepsis, but in this big meta-analysis of 22 studies, including 2,255 infants, they have specificity for 74 and the sensitivity 62. So really the CRB, especially when we ask for CRB in the initial evaluation of patients with the suspected neonatal sepsis, unlikely to be aid in diagnosis. Maybe the procalcitonin, it work or perform better than CRB. This is very big randomized control trial done by Dr. Stoker over 3 years. They include 1,700 neonate, more than 34 weeks of gestation, and they take different serial procalcitonin level at 12, 24, and 72 hours. What they found? They found actually the area under the curve for those patients at 12 and 24 hours, it is poor, less than 0.5. And if we take the procalcitonin at 36 hours, more than 0.9. So as you know, if we have area under the curve more than 5.7 or more, it will help us really to discontinue the antibiotic. But here, the procalcitonin, it helps us. But actually, after 36 hours, it seems to be 36 hours already the blood culture come, the result come, and you will decide to DC the antibiotic. The average antibiotic duration, when they use this study, they found 55 hours in BCT group and 65 in standard of care group. So no big difference, but actually procalcitonin, it is one of the biomarker we use it sometime in discontinuation in high risk area in antimicrobial stewardship. What is new now? We have interleukin-6, and this is very recent study. One of them, it is a retrospective cohort study. They include 1,695 infants with 109 culture-proven sepsis. They found the interleukin-6 with the sensitivity of 75 and specificity of 81 with high negative predictive value. So it is worth. We don't know. We'll see the second study. Here we have meta-analysis of 31 study for early onset sepsis with high sensitivity and high specificity, again with high negative predictive value. Dr. Kanti, he said that sepsis in neonate is rare depending on the culture. Maybe it cannot be explained with the high negative predictive value. A lot of biomarker talking or helping in the future to guide us in diagnosis of neonatal sepsis. So what is coming? I think we have to think about the non-invasive biomarker in helping us of diagnosis of neonatal sepsis. 1 minute. Thank you. Okay, so for heart rate characteristic, I think all you know about the monitoring of heart rate. It can help, especially before the baby crash, and also it will help us in decreasing the mortality of the newborn. When we combine the heart rate monitor with the biomarker, it seems to be really decrease the mortality and the antibiotic. I will not go in detail in this recent study. One of them maybe talked about the intestinal microba, and Dr. Joseph knew, I think he discussed it yesterday or before yesterday. It has a role in finding the patient with high risk of NEC. The pulse oximetry, the VO2 and BCO2, they found it helped us in diagnosis of neonatal sepsis. So we have a lot of biomarkers, but we again will go to Dr. John biomarker. So we have to look to the biomarker, involve all these criteria with non-invasive. I don't know, the last one, septic check, maybe somebody hear about it, I read about it, maybe in the future we found it. They said this is as a sensor, you will put it in the hand of the infant. If turn yellow, monitor the patient, obtain the culture, and if came red, start empirical antibiotic. I think by this time, if that happened, so no need for ID people. So today, we have to look to the CBC, differential, CRB, BCT, try to trust your blood culture, but tomorrow we have to work hardly on the biomarker with the collaboration of engineering, biomedical, and computer and electrical. Our guideline, this is really a huge work done by CNS. Really, I want to thank our leader, Dr. Jassim, Dr. Yassim, and this is what we need actually. With all this, we don't have unified standard guideline in neonatal sepsis. This is what we need actually, and they did quality assessment of clinical guideline. It is a systematic review. They retrieve more than 4,000 record, and they compare four of guideline. It will publish soon, as Dr. Jassim mentioned. Really, I want to thank them to consider me in this guideline. There is we are together actually as ID and neonatology. We have in this month the World Prematurity Day, followed by Antibiotic Awareness Week. So this is the role of antimicrobial stewardship with the neonatology in standardize the treatment of neonatal sepsis. Thank you very much.
Our next topic is hypoxic ischemic encephalopathy, presented by Dr. Omar Khatib. Dr. Omar, he's a consultant neonatologist at King Fahd Medical City. He is the chairman of Neonatal Accreditation, Compliance Policies and Procedures Committee. Also, he's a chairman of NICU Infection Control Committees and Vascular Access. Dr. Omar, please.
Presentation. Presentation.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم، والحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. ثم أما بعد. Thank you, Dr. Jassim, and thank you, Dr. Amal, and thank you, Dr. Rana, for the presentations on the previous guidelines. I will present the work our group did regarding building a new national clinical practice guideline on the management of HIE in neonates. I have no personal conflict of interest to declare. This study, this work was funded by the Saudi Neonatal Society. The objectives of this presentation is to give a synopsis on HIE in brief, yani, and why do we need a national clinical practice guideline on HIE, and then the journey we took to build our first Saudi national neonatal CPG. مين هم الجروب members وإيش هي الأجري to instrument دكتور جاسم اتكلم عنها, and what was our search strategy to build this CPG, and then what are the future directions, inshallah. So HIE, probably everybody here knows hypoxic ischemic encephalopathy, أحيانا بنسميه birth asphyxia. It's a devastating condition that may result in death or severe neurological injury in babies who survive. A mild to moderate injury causes parasagittal watershed infarcts in full-term neonates. It can cause bleeds in preterm neonates as well as term neonates. Severe injury causes deep gray matter in both term and preterm infants. And unfortunately, there is no cure for the ischemic injury that happens due to decreased blood flow to the fetus before or during birth. But there are ways to prevent the complications or reduce the complications. HIE is a costly disease, مكلف جدا على الحكومات. It's estimated that one case of cerebral palsy that results from HIE in the United States, one case costs $11 million for the lifetime. تخيلوا $11 مليون بيكلف الحكومة الأمريكية على الطفل واحد عنده cerebral palsy from HIE. So it's a huge problem everywhere. So it's worth an effort for a quality improvement on a national aspect. And فعلا, this is a problem that needs to be addressed. So ليه محتاجين national guideline؟ أو عموما ليه بنحتاج guideline في أي حاجة في الطب؟ Excuse me. So the reasons are to influence practice. إنه إحنا you want to make the practice better everywhere. That's the reason you build an HIE guideline. The aim of the clinical practice guideline is to synthesize the best available scientific evidence and to make it easier for clinicians to stay up to date on the latest evidence-based practice. Unfortunately, and this is one of the challenges that we face everywhere, that some clinicians still think that those guidelines are overly prescriptive. يعني, they want some freedom. They want to, they want to treat or manage according to their own beliefs. This is a problem I think most of us face in, almost every institution, that there is somebody who thinks that they know something better than the others. But the guidelines are intended to improve the management by everyone. So if I write a guideline and there is some physician شغال في منطقة نائية, he might know better than me. I will not claim that I know better than everybody, of course. لكن if he knows better than me, then I should be influenced by him. يعني لو هو فعلا he thinks that there is something better in the management of HIE, why should we make it confined to that place? خلاص خلي الكل يستفيد منه. So this is the aim of writing a guideline. احنا بنكتب guideline. If we find that there is a feedback from a certain place that says, listen, this step in the guideline doesn't work, then we as a central group should improve this guideline so that every baby born in the Kingdom of Saudi Arabia will benefit from this new improvement. So this is the aim of writing a guideline. So what did we do? We reviewed all the literature. We critically appraised the quality of recent CPGs. And when I say recent, it means within the last 10 years. آخر 10 سنوات أي clinical practice guideline انكتب في ال HIE على مستوى العالم we reviewed على مدار 10 سنوات. And then we mapped our recommendations. This protocol, as Dr. Yasser Jassim mentioned, was registered in the Prospero, and it was guided by the PRISMA statement. Our guideline review group included 7 expert consultant neonatologists. الآن راح أكتب أسمائهم. One of them with expertise in systematic reviews, 2 consultant OB gynecologists, a senior nurse, a medical and healthcare librarian, and a CPG methodologist with a background in pediatrics. This is the group. Dr. Yasser Amir, he is a pleasure to work with. Honestly, I don't know if he's here or not, but one of the best evidence-based experts in this field. He is amazing, Dr. Yasser. Dr. Jassim Al-Nabris, he is also the CNS representative. Dr. Muhammad Abdel Maula من King Fahad Armed Forces في جدة. Dr. Ayman Taj Sir Abdel Qadir, a neonatologist in King Saud Medical City. Dr. Asma Al-Mazroui, she's a neonatologist and neonatal neurologist. We have 2 actually neonatal neurologists في المملكة. واحد فيهم في مدينة الملك فهد الطبية الدكتور عبد الله هواش العنزي, and the other في جدة الدكتورة أسماء المزروعي. Both of them were members of this group. دكتور إبراهيم الحفظي من القطاع الخاص في عسير مستشفى السعودي الألماني. دكتور عبد الله هواش, as I mentioned, the other neonatal neurologist. Dr. Yasser Sabr is an OB gynecologist في King Saud University في الرياض. وميس ليال, she is a medical librarian. ميس عائشة الشلوي, she's a staff nurse في King Saud. دكتور أحمد الأيوبي, he's a consultant OB gynecologist في مستشفى اليمامة. And myself. مصادر السيرش كانت كل ما تتخيلوا. We did not leave anything notes. Everything has been searched for. So كل ال CPG databases, كل ال bibliographic databases, وكل ال specialized professional societies. So خلصنا search في CPG database, رحنا على ال PubMed وال Embase والسينال, خلصنا search فيهم, رحنا ندور في مواقع ال professional societies اللي هي الأمريكان أكاديمي, الكنديان Pediatric Society, البريتش Association of Prenatal Medicine, الرويال College of Pediatrics and Child Health, والسعودي Neonatal Society, as well as also الأستراليان websites. So يعني ما بحثنا فقط في البابميد مثلا وخلاص, لا, دورنا في كل مصدر ممكن يخطر على بالكم بالنسبة وين ممكن نلاقي a clinical practice guideline in English. طبعا يعني أشياء اللي هي non English we did exclude. كل أي CPG تم اختيارها كانت original de novo, يعني خاصة بهذا المكان. لازم تكون group authorship, يعني ما ينفع أن أختار CPG for review written by one person. This was excluded. Any CPG written by a single person was excluded. Has to be either English or Arabic and with international or national scope. And the draft was according to the PRISMA statement. 2 reviewers, myself and Dr. Muhammad Abdel Maula, conducted the title and abstract screening of the CPGs. And 2 other reviewers double-checked the full text screening, Dr. Yasser and Dr. Jassim. Any disagreements were resolved through a focus group discussion. We met probably 6 times. We have a WhatsApp group that is 24/7 live, where we are discussing any thoughts, any ideas, any conflicts, any يعني أي واحد عنده فكرة معينة بيناقشها في المجموعة, as well as Zoom meetings. The search and the screening for eligible CPGs were updated before the submission of the manuscript. طبعا ال agree to instrument was mentioned by Dr. Jassim. Those are the domains of the agree to tool or instrument. Domain 1 level scope and purpose. Domain 2 stakeholder involvement. Domain 3 rigor of development. Can you bring water for me? Thanks. Domain 4 clarity of presentation. Domain 5 applicability, and domain 6 editorial independence. So everything, as you can see, is objective. We avoid it totally ان احنا نكون subjective، ان كل واحد يفكر بمزاجه وبرأيه. لا خلاص في objectivity. This is the way that we are going through. This is the way that we are going to evaluate all CPGs that will come across. It's an agreed upon tool that every CPG on the search result will be evaluated on this tool اللي هي agree to. Thank you. A total of 4,500 records were retrieved من السيرش تبعنا. 19 from CPG database and professional societies. After the title, abstract and full text screening using Ryan, only 2 source original CPGs were found to be eligible for the agree to quality assessment step. يعني من ال 4,524 result, only 2 guidelines were eligible according to the agree to instrument. ايش هم التو؟ الCPS اللي هو الكنديان Pediatric Society والكوينزلاند اللي هو الأستراليان. 2 reviewers conducted the screening and 2 additional reviewers زي ما أنا كتبت في السلايد السابقة resolved any discrepancies through discussion. So هذا البحث العظيم تخيلوا 4,520 result فقط 2 كانوا eligible للأجري to, which is a very rigorous way to critically appraise any guideline on the planet. Any guideline حطوا على الأجري to وشوف هل هو CPG كويس ولا مش كويس. سبحان الله وجدنا فقط 2 اللي هم الكنديان والأستراليان هم اللي فعلا كانوا توب. والأستراليان كان أفضل شوية من الكنديان بالنسبة للسكور على الأجري to. الأستراليان كان higher or more superior than الكنديان. This is the process that we went through اللي هو السيرش والريزلتس وهي الأشياء. By the way, this will be published إن شاء الله. ال 2 eligible CPGs اللي هو Queensland Clinical Guideline تبع أستراليا. ده التايتل تبعه HIE Maternity and Neonatal Clinical Guideline Queensland Clinical Guideline. اليير اوف publication كان 2021. والCPS اليير اوف publication 2018 لكن في new CPS guideline we also included and there is no ما فيش أي significant change yet من 2018. By the way, we took permission from both author groups of the Australian and the Canadian, and alhamdulillah we were granted permission to use them. And before we use any guideline on a national base, you need to make sure that إنه الناس اللي كتبوا هذا الجايدلاين يسمحوا لك باستخدامه في بلدك عشان ما ايش we have to be legal, we have to be systematic and you have to be منظم وإلا you are يعني you are playing a bad role model. تمام؟ نعم؟ بالضبط. Thank you. الانكلوجن كرايتيريا طبعا I will not go through ايش هم الانكلوجن والاكسكلوجن كرايتيريا بالنسبه للهايبوثيرميا لكن I always tell my fellows that to know what are the inclusion criteria في ال HIE take it the other way around. HIE متكون من 3 حروف HIE امشي بالعكس. You need E which is encephalopathy. So first thing you need an abnormal neurological examination, a baby that's presenting with abnormal neurological examination. And then you need the HI as the cause of this E. بمعنى إنه this encephalopathy has been caused by an ischemic insult. not by anything else. ليه؟ لأن encephalopathy in neonates can be caused by inborn error of metabolism مثلا, can be caused by intracranial bleed, can be caused by many things, right? But if this encephalopathy is precipitated through an ischemic injury, then this baby qualifies for cooling ببساطة شديدة. طيب إذا الE encephalopathy is by examination, الHI is by history. So كان في مثلا abnormal fetal heartbeats أو late fetal decels, كان في مثلا antepartum hemorrhage, تمام؟ And then في مثلا poor cord gas pH, في resuscitation at more than 10 minutes of age, في كل الاشياء اللي هي بتدل على انه الانسفالوباثي سببها ischemic insult. Okay. So those are the inclusion criteria. Exclusion criteria طبعا اي بيبي عنده major congenital anomalies او عنده طبعا اللي على اليسار اللي هو السي بي اس واللي على اليمين اللي هو الكوينزلاند. اوكي. وهكذا الفيدنج السي بي اس تسمح بالايرلي مينيمال انترفيد، الكوينزلاند ان بي او during الهايبوثيرميا. في literature evidence انه الفيدنج is actually safe during hypothermia. sedation كان في اختلافات بسيطه بينهم، الثيرابيوتيك هايبوثيرميا وتارجت تمبرتشر كانوا تقريبا زي بعض. فبعد ما خلصنا review and we discussed the two guidelines, we adapted to a local practice. We drafted the first Saudi national HIE CPG. We got permissions, as I said, and then we submitted for publication. And then the future directions, inshallah, will get feedback من centers across السعودية كلها. We'll check compliance and we'll check the challenges facing individual centers. And inshallah, we aim to update such a CPG every few years to make sure that we are catching up مع أي new evidence في management of HIE. وشكرا جزيلا.
شكرا دكتور. دكتورة. دكتورة أمل، دكتورة.
For the speaker kindly to attend here for the discussion.
طيب anyone has any questions?
For Dr. Rana. Yeah. Yeah, we'll just wait for her.
She can't hear you, no.
Yeah, it's okay. I'm Buenafe, I'm a NICA professional and NICO developmentalist. And I just want to have a recommendation when it comes to the neonatal sepsis assessment and during the early detection. As a bedside nurse and as a NICO developmentalist, developmentally wise, if recommended, and this is under the European guidelines, US guidelines, and this is found with all the researchers in Sweden and USA as one of the early detection. If the nurse is developmentally educated and oriented, there are 4 steps that we can assess early detection of neonatal sepsis. Number 1, we have to include the feeding intolerance of the baby for the first 24 hours. And you can find this in the European guidelines about the 4th step. And each gestational age, they have their own how many ml of feeding they will going to tolerate for the first 24 hours per ml per Q2 hours and per Q3 hours. So in this regards, if the nurse were not going to know about the feeding tolerance of each newborn according to gestational age, they're going to feed according what they want and how they're going they must be the neonatologist or the physician should give them the proper instruction on how many ml on the first 24 hours, because most of the nurses were going to give according to the like 30 ml is not really feasible for the first 24 hours, especially for the small gestational age. So they were going to find out that the baby is vomiting, of course, intolerance.
So what is your question?
So it's a recommendation, doctor, that it should be the nurse should know what is the how many ml they're going to give, because I'm going to give the early assessment in order for them to detect for the early referral as well. So the feeding ml of how many going to give in each gestational age. Number 2 is according to the cardiorespiratory instability and also hemodynamic. They have to be strict on that. Number 3 is the color. If the baby will going to give them the cues, what color they will going to give, the nurse should know that this is already the baby is stressed, and giving them already the sign of early signs of neonatal sepsis. And another thing, hypothermia or consistent. In spite of everything that we give, we keep the baby warm, we do the kangaroo care, and there's still the consistent of hypothermia. So this is one of the early sign. And another thing is the nurse should know about the state that not the first 24 hours the baby was delivered and the baby is sleeping. And this is one of the guidelines that Dr. Arana discuss about the interleukin. So the nurse should know all those things. If there are 6 states of baby when they're going to give you the sign. So one of this one is the deep sleep. The number 1 is deep sleep. So they should know that the baby is not sleeping well or what. Deep sleep also one of the signs that for the first 24 hours that early detection of the neonatal sepsis. So this is a recommendation as the NICU developmentalist.
Thank you.
Thank you.
I think the second question, Dr. Abdurrahman, was.
Mike, شكرا جزيلا for the 3 or 4 elite speakers. أنا كرئيس الجمعية كان على عاتقنا أن احنا we have to finalize this guidelines by 2022 and I think almost finished. لكن السؤال for Dr. Jassim, Dr. Omar and the others, how we can implement it? What is the force of our guideline to be implemented national in the private sectors and all institute? If you allow me for the second question, for Dr. Rana, we are not fighting. We are living in peace as neonatologists and ID. And the rule always, when we start to debate, we need to put the antibiotic because the baby is bad hemodynamically, and you want to stop the antibiotic because the culture is negative. What will be our guidelines or what's the role of the stewardship in controlling this debate and controlling this fight? شكرا جزيلا.
Thank you, Prof. Nimri. Thank you, everyone, for attending this very important session about clinical practice guideline. Honestly, implementation is very challenging, and we think about it in board of director before we start the guideline. And even on the level of teams, we have many meetings, as Dr. Omar and other team mentioned, that we did WhatsApp group, Zoom meetings, and a lot of meetings just to discuss how we can come up with very good clinical practice guideline and how to implement that guideline, not to do as before. We have a lot of efforts before, and it's end up in shelf or anywhere, but not implemented. So from our meetings and our colleagues' mind, we have 3 major issues. We need support, and this was very support from Ministry of Health, Dr. Ali Al-Mudir, from SNS. And lastly, we met with Dr. Sayari from Saudi Health Council, and all of them support our initiation and our movement. So support was very well, and inshallah it will give us good indicator that we can go further. The second implementation issue, that we include teams from everywhere. So we cannot say like pediatric ID not involved, so they will agree or disagree, for example, with some of ideas or biomarkers or something like that, or HIE, for example, some neurologists or other specialties. So we involve all specialty, concerned specialty, and we involve even other health sectors. Like private, they can say we are special institute, so we involve private. We involve Ministry of Education, universities, MOH, and all health sector in Saudi Arabia. Last thing was in implementation that we need to consider different resources. And this is thanks for all team again, I'm saying, because really they did a great job, that they were discussing MRI and HIE. Should we do it? Should not do it? Once, twice, at what age, at what time? So they will considering, honestly, maybe a lot of work. It is not written in slides, but it have been done very thoroughly discussion about all those things. So we don't like to say for peripheral area that we do MRI and then they will stuck with our guideline and they cannot do it. So we discuss everything and we tailor it to all resources. If we have very high good center like National Guard or King Saud or any good tertiary center, or we have periphery. So this is three, I think it give us good future for implementation. Thank you.
Dr. Majid.
Okay, thank you, Dr. Abdulrahman. Actually, before answering your question, really we are not in fight, because as you know, antimicrobial stewardship, it is multidisciplinary team, and you or the other as neonatologists part from our team and antimicrobial stewardship. And it is well known, antimicrobial resistance now, it is really the big problem over the world. Even in by WHO stated in 2035, it will be the first cause of death at that time. So as antimicrobial stewardship, it play a role actually to controlling the use of antibiotic or improper use of antibiotic as a core intervention or a strategic intervention to control it. A lot of literature talking about the antimicrobial stewardship role in ICU, especially. Maybe I didn't talk about it in detail. The publication by Dr. Joseph New, when he's talking about the prolonged use of antibiotic in the NICU can cause alteration in intestinal microbe. So maybe risk for NIC. So to control it, we have to work as a team to avoid improper use of antibiotic, to avoid all this problem with all complications. Thank you.
شكرا دكتور. Majid.
Thank you. The way I understand that these guidelines you are presenting, as if they are a legal document and people has to follow. And they are not legal, are they? I know it is good to have guidelines, but you are asking people to follow this guideline, and if they don't follow them, then they are in trouble. And the legal problem in the country is rising. So we have to be very careful when we put the guidelines. As you just mentioned, that people in the periphery, they don't have the resources. And if your guidelines, you cannot have guidelines for a tertiary center and you have guidelines for periphery. You have to have a guideline.
I will answer your concern. What's your name?
Can I finish?
Yeah, go ahead, please.
And if you have a guidelines and people have to follow, and then there's a problem, then the people at the periphery, they're going to be in great trouble if these guidelines fell into the hand of lawyers. Now, let me give you just a simple example. You mentioned that all babies should have a pulse oximetry between 24 and 36 hours. What do you do if the obstetrician discharges the babies at 12 hours or at 8 hours sometimes, and then the baby turns up to have sciatic heart disease, and they see the guidelines, and then why you didn't do a pulse oximetry for this baby, and they will be in trouble. So I think if you want to implement it all over the kingdom, it has to be legally approved rather than only from the society. And I repeat, I think we need the guidelines, but it has to be done properly and approved before get implemented.
طيب بسم الله الرحمن الرحيم. هو أنا يعني I'm the chair of Policies and Procedures Committee في King Fahd Medical City for the last 5 years. And so what you are talking about here is the difference between a policy and a guideline. If we titled this document as a policy, then every center across the kingdom has to follow precisely. A guideline هو دليل إرشادي that gives a range of practices to follow. Is it a legal document? It is a legal document. Not yet, but it will be a legal document. If an obstetrician discharges an infant without a pulse oximetry before the 24 hours, he needs a justification for this. We are not saying you are malpracticing, but if you don't follow the guideline, then you as a physician need to justify your practice. A policy, no. A policy you should follow, and if you don't follow the policy, you are malpracticing basically. So a guideline, if we go through what we wrote in almost every guideline in those presented, you will find that there is a range of acceptable practices, وفي النهاية في clinical sense. يعني أنا لما أكتب guideline براعي جدا إنه في حاجة اسمها clinical sense، في understanding، في difference in practice. It's في range I can choose from. But yes, I can not follow sometimes. I'm allowed to. ولذلك مكتوب مثلا MRI if available. So أنا as a guideline writer, I know that some places don't have MRI. So what if I don't have MRI? Then ultrasound can replace the MRI. So, and that's why, as a writer, you need to give the people options. So, is it legal? Yes, it is legal. لكن هيعتبر legal في حالة إنه هو أنت, if you don't follow, then you justify, at least justify. That's it. As simple as that, يعني.
If you allow me, Dr. Majid, just to say.
I think
Dr. Majid, let's just finish because you asked us a very important questions and we need to address that important questions. And I will be in the hard side. What I mean, I will be in the hard side. In the hard side, whenever we do a clinical practice guidelines, you look into all the issues you mentioned. We look into the legality. We look into the applicability, and at the same time, we look into the obstacles and the challenging. So what you are mentioning, Dr. Majid, this is a challenging and this is an obstacles as well. So this is the reason behind the first question Prof. Nimri asked Tamam Jassim about the applicability and how we will do that. We know that the whole kingdom, there is a peripheral hospital, there is a primary, there is a secondary, there is a tertiary. In fact, you help them out by these guidelines to say, wait a minute, I have a problem here. So the policy makers, as I indicated in my presentations, they do the quality improvement. What we have the issue here, how we can address it from the legal point of view. In fact, I'm more right now into get that clinical practice guidelines as soon as possible. It's just to overcome this challenging and to overcome this obstacle, Dr. Majid. Thank you.
شكرا دكتور عمل.
Thanks for the speaker. Assalamu alaikum, sabah al-khair. The question to Dr. Amal, as you mentioned, the newborn care is very important, and this it addresses like 90 or more than 90% of the babies. My question regarding the involving the mother in the care and rooming in the babies to their mothers. I hope you mentioned this in your guideline, because in many places the babies are separated from their mothers. And then probably also another point is the post-discharge care and the follow-up. The follow-up again is very important, and probably we need like written materials for the mothers to read, a standard, something from the Neonatology Society for the mothers to follow exactly what is written, because there are many things written or in the internet or so, are the companies, especially the formula companies, they formulate a lot of things probably we don't agree with. So I think these points needs to be addressed in your guidelines.
Absolutely, I agree 100% with you, and already we are going into that, because the information has to be clear for the parents from the beginning, and the beginning actually from the antenatal, even not postnatal. So everything should be set from the beginning. So I agree with you 100%, and already we covered part of it, and we will continue to cover all of it, inshallah, bi'idhnillah.
Thank you for the speaker.
If I can, Dr. Rohit, if I can have 1 minute, Dr. Jassim, just 1 minute, sorry, because we are late, but a few points I left it from my presentation because of time. We face a lot of obstacle, and what we are discussing today, it is reflecting that the issue is not simple. And all teams from different sectors, from different specialty, sit many times and discuss, and we disagree with each other, and we try to find what is more suitable for our society and national guideline. So we have a lot of obstacle. Team with different specialty to bring together, team with different opinions from different health sectors to motivate the team. It was very, very challenging to us. It's not just the final words what we are presenting, but really it make us give us a very hard time. Also, the concept of clinical practice guideline was a very new concept for a lot of us. There is, as usual, we discuss in many places that we have a lot of guidelines, a lot of policies in different health sectors, and everyone like his sectors. There is a lot of groups pop up after we start, and we try to accommodate them with us just to make one group working. So we have better implementation, as Prof. Nimri said, and this has happened many times. There was a very big challenging with health reform. That rules were changing. Saudi Health Council versus Al-Hayat Saudiya versus Ministry of Health. It was a lot of change. So even our change in the guideline was delayed because of that. We were following Saudi Health Council. Then we changed to another. Then Al-Mawarid al-Bashariya. Then it gave us sometimes delay and some consideration in between. Copyright permission, as Dr. Umar said, that we have agreement for HIE, both of them, but we have rejected by NICE, and they request very high, 50,000 riyal just to give permission for ADAP. So we have even the permission challenge. The feeding protocol, already we started with a very distinct group, but we couldn't progress with that because of that we need de novo group, but we put it on the second wave guideline, which is very important feeding protocol. We have one which is working very well, but we need to upgrade it. I want to say to all our colleagues, like Prof. Sajjad what said yesterday, you are most welcome, anyone, to participate with second wave. If anyone like to participate, please send to society your name, and you are welcome. NIDCAP professional, we forget, I think, to involve. Sorry, Benef. I think NIDCAP professional, very good specialty we need to involve. Last thing, please, what we present is still not finally approved. So if one make a screenshot of hard copy, use it for your personal, but inshallah after final approval, because for sure even final approval it need some changes and editing, then you are welcome to use it, and thank you.
Thank you for our speaker. I think we can end, sorry for this because of the time.
Dr. Nimri, you can go for a break
And
now.
just to answer Abbas. Abbas, we have now Majallat al-Walid. It's in Arabic. It's mainly for the mother. And you can get the second, inshallah, volume to be with you. Your responsibility to write for us what is the post-discharge plan. Well, inshallah. Tam. Khalas. So this is al-Walid journal, and Abbas is going to get and write the second issue بإذن ta'ala. Shukran jazilan.
So you can go for a break for 10 minutes. Half an hour, okay.
half an hour.
Okay. Half an hour, 30 minutes. Thank you very much.
Nice.
Thank you.
دكتور مطري حياكم الله تفضل. ما ايش مسمينه هذا السيشن حقنا؟ مسمينه السيشن 9 مهما له اسم وات ايفر. فانا حقدمك وبعدين انت تبدا بالتقديم طرف العويضه. ايه communication of transfusion. Did I send you that session ولا ما ارسل لك؟ خليني ارسل لك اياها. خليني ارسل لك اياها. عندنا شويه وقت. لا انت راح توصلك الحين. السلام عليكم. صباح الخير مرة ثانية و you are welcome back to the 9th session of the 21st annual meeting of the society. This session we have 4 presentations. And I will moderate it with my colleague, Dr. Abdurrahman Al-Matari. Abdurrahman Al-Matari, he is a consultant neonatologist and the leader and program director of fellowship at King Fahd Medical City in Riyadh. Abdurrahman, go ahead.
بسم الله الرحمن الرحيم. السلام عليكم. أسعد الله صباحكم جميعا. Okay, our first speaker going to be Dr. Tariq Al-Uwaida. He is a consultant hepatopathologist. He graduated from, he obtained his College of Medicine from King Saud University Medical at Abha, and he obtained a fellowship from Australia. Also, he is a fellow, American College physician from Philadelphia. Thank you. Dr. Tariq, you can start.
Assalamu alaikum. It's my pleasure and honor to be here among neonatologists and to share experience. And I'll talk about the blood products and the complication. All of us knows the blood is quite important, and the blood is quite precious products, not easy to be found. Most of the time it's human to human transfusion. So the optimal use and better utilization of the blood products is a mandate everywhere, and it will continue. During this lecture, I'll try to have some introduction, then just explore what are the blood products we have available in the blood banks for patients. What are the blood substitution, which we are trying to push more for blood substitution rather than the blood, because as I mentioned, blood is most of the time is not easy to find, and whatever number of donors we have, still we will have more demand than the supply. Transfusion related complication is not a simple thing. It's very complicated. I'll try to shed light on some of these points. And finally, I will just shed light on the transfusion in the neonatal period with some of the guidelines that being recommended for that. Transfusion, if we go to the history, it was started in 1600 by Samuel Babis, and then the first successful human transfusion was in 1828. Then Landenster, who is the father of the recent blood transfusion, almost 100 years or 120 years, described the ABO group, and then Liffen described the RH group, which are the two major groups that we concentrate on to give the compatibility of the blood and minimize the incompatibility. As we all know, the transfusion is meant to improve anemia, restore volume, improve oxygen delivery, suppress ineffective erythropoiesis, particularly in disorders where there are hemolysis, chronic hemolysis like thalassemia and sickle cell. And in addition to that, we have blood products that will help us to stop the bleeding, and sometimes we need to use blood products that would fight infection. I'll try to go through some of these and explore what are the products and where we can use these products and what are the complications that may happen with these products. Whole blood, which is the first collection, and it can be used as a whole blood or can be fractionated more, and we will talk more about it. And that fractionation can result in red blood cells or backed red blood cells, platelet, plasma. And the plasma is a fall of many things that either we give it as a whole fresh frozen plasma, or we fractionate it to factors, immunoglobulins, or albumins. And finally, the least used granulocyte, which is only used in particular situation where we need granulocytes to fight infection, and we have no production, particularly post-bone marrow transplantation or in severe aplastic anemias. This is the whole blood, which we collect either automated or we collect donor, single donor, and it goes through first centrifugation, where we separate the blood, and then we go to the second separation, where we get three products, which is the red blood cells, the platelet concentrate or platelet, plasma poor platelet, and plasma rich platelet. The blood safety is quite an important, and there is a lot of concerns about the blood safety. And whatever blood we do, whatever test we do, as being recommended by WHO or the American Association of Blood Banking, of all these viral and protozoal infections, still, as you can see, this is the recent data from WHO shows no blood is completely zero of viral infection. We may reduce the incidence of having the infection to 0.002% in high income countries where the infection and the quality of testing is high, or it can be up to 0.7% in some of the low income countries. So we have to keep that in mind, because this is one of the major complications that may happen to the patients, and it's one of the drive where we ask not to transfuse unless there is a need for transfusion. When to give a blood, that's a clinical decision, and that clinical decision should put in mind not only the need, but also the expected complication. Symptoms of anemia is one of the drive for transfusion, but if we can solve this with substitutions, and talking about substitution, not only the blood substitution, but also the adjuvant substitution, like iron supplements, B12 supplements, folic acid supplements. If we have symptoms that allow us to do that, then we would prefer to do that rather than give blood transfusion. Signs of ineffective erythropoiesis, which means that the production, even if you give the iron or if you give all the elements, will not be enough. So in that situation, you will be forced to give a blood transfusion. But you need to know how much level of the hemoglobin that you need to achieve, so you don't over transfuse and cause more complications. Bleeding, we don't transfuse in bleeding now. With the current availability of most of the factors, we minimize the transfusion of FFP, and as I mentioned, infection, we use the GCSF or others rather than the granulocyte, except in a special situation. If we go one by one through the blood products, the whole blood, I just wanted to highlight that the fresh whole blood was an old practice, which we stopped it long time, but now it's coming back, and coming back for many reasons. Trauma is one of the reasons. I will not go in details about it, but I would like just to highlight that fresh blood in patients less than 2 years demonstrated decreased blood loss in pediatric population, and maybe considered, especially in complex situation where the patient have lost all the blood components. Red blood concentrate, which is available in most of the hospital in different preservatives that make it 21 days, 35 days, or 42 days. For you in neonates, we don't go in these. We usually prefer to have a fresh blood within less than 7, even if it is preserved in 42 days. We don't allow that, and particularly that because the patient cannot tolerate any increase in the potassium in the unit that can cause the potassium hyperkalemia and cause all the complication. Compatibility is an issue with the red blood cells, and we stress on the compatibility because you may have a problem with the compatibility in neonates, especially when there is no enough testing being done to explore the presence of transferred antibodies from the mother to the baby. And we know that the antibodies can still continue in the baby for some time until it decreases or cleared from the system. The usual pediatric dose of 10 to 15 is more achievable to achieve 2 to 3 grams per deciliter. And in patients with thalassemia, as I mentioned, which may not be a case in neonates, we need to keep a higher blood because of the hemoglobin F, which is of a high O2 oxygen affinity. The compatibility is an issue, and we need to be sure that the blood transfused to the neonate within the acceptable compatibility and phenotype the baby and phenotype sometimes the mother to see if there is a discrepancy and try to select those who are compatible phenotypically and compatible by testing. Leukoreduced is a mandate. We need to filter all the blood products because that can cause the cytokinemia. And again, the neonates cannot tolerate the cytokinemia. And as I mentioned, it should be a fresh blood less than 2 weeks, ideally less than 7 days. If patients who have a history in the family of IgA, we prefer to give IgA deficient or in patients with IgA deficient plasma infant, we need to give a washed blood where we remove most of the plasma so the anaphylaxis cannot be happening here, and irradiated in some situation can be used. Platelet concentrate is important. We with the availability of different type of platelets, single donor or maximum donor of platelets, we need again to look at the threshold, when to transfuse, what type of transfuse, and what is the dose of platelets. For fresh frozen plasma, we are trying to avoid fresh frozen plasma by using the coagulation factor concentrates, yet sometimes we need to go for that if we have patients who have DIC or there is an exchange of massive transfusion. As I mentioned, granulocyte is the least used, and it's only available in very tertiary center where it needs to be supporting bone marrow transplantation or patient with severe infection. The pharmaceutical blood substitute, there are many, and every day we have a new substitute. Most of the plasma coagulation factors are available from fibrinogen until factor 13. Recombinant factor 7 is available, prothrombin complex and solvent detergent plasma and albumin. All these available will minimize the use of a direct transfusion from direct blood components. Finally, the 2 points I would like to highlight is the neonatal transfusion is a new coming focus of the transfusion. And as you can see, this is the British Blood Transfusion Society new guidelines, which I would recommend that you go through it because it has a lot of information. Although the optimal hemoglobin level, as they had reviewed the literature, it's not yet been defined, and we lack enough data to support the use of optimal. But what we learned from their guidelines, that data suggests an increased risk of brain injury, 12% versus 0 for those with lower transfusion at lower hematocrit transfusion threshold compared to the higher trigger. Another study had confirmed the same finding. Untreated anemia has been associated, as you all know, with motor growth and cognitive delay. So we need to keep eye on the hemoglobin and raise it. If it's not raised by the hematinics, iron, B12, and folic, we need to support that with the blood transfusion. In surgical patients, decreased post-operative mortality rate was associated with in patients with pre-operative hematocrit of more than 40%. This is again from the guidelines. It showed a different cutoff, which was adopted by different guidelines. And because of the sake of the time, I would like to skip that and move to the last 2 slides, which are the adverse reaction for transfusion in common and in neonates. lifelong transfusion, particularly for patients with sickle cell or patients with aplasia or bone marrow failure, especially those who born with bone marrow failure, congenital bone marrow failures, get exposed to a lot of transfusion. As a consequence of that, alloimmunization happens, and they develop antibodies at different antigens and make the transfusion more difficult and complicated. So we would like to prevent this by doing early phenotyping and phenotyping match, not only compatibility by the testing, but also compatibility by phenotyping. Non-hemolytic transfusion reaction is one of the complications. TRALI is not common in neonates, but it's more common, particularly if we are using blood products coming from females donors, where they have exposure to the antigens and forming the anti-HLA antibodies. Allergic reaction is quite common, and particularly it happens with patients who get exposed to plasma products, both the platelet and fresh frozen. Febrile transfusion reaction is quite common, and that can happen more frequently for patients who receive unfiltered blood, where the cytokines transmitted to the patient and increase the temperature. And finally, the platelet refractoriness, which is a consequence of multiple platelet transfusion and result in unresponsiveness to platelets. All the viral infection is continue to be a risk. As I showed you, the risk is quite small, but it's there and need to be kept in mind, and surveillance should happen. And finally, particularly for neonates, red blood cell transfusion can be associated with necrotizing enterocolitis, retinopathy, intraventricular hemorrhage, and iron and folium overload. All these needs to keep in mind and try to prevent it rather than expose the patient to the complication. With that, thank you for listening, and back to the podium.
Thank you, Dr. Tariq, for this nice presentation, though we have still time. So we'll go for the next speaker, Dr. Jibara. Dr. Jibara is well-known neonatologist in Saudi Arabia, actually, and everywhere. Hard worker and famous. She's a director also of Saudi Neonatal Resuscitation Program, and she is a consultant at King Khalid National Guard Hospital in Jeddah. And she is a member of American Academy of Pediatrics. So, welcome.
Thank you very much for the moderator for introducing me. It's my pleasure to be here. I have one disclosure. I will not talk about resuscitation. So, what is the topics? Just okay. So I'll start with a case. So we have this baby girl who was born to a mother, gravida 4, para 3, born at term by spontaneous vaginal delivery. It was through meconium still liquor. Her Apgar score was fine, 8 and 9. Her cord blood gas was also fine. So baby sent to the normal nursery. At 2 hours of age, they called the fellow call because the baby had cyanosis and oxygen saturation was 80 to 85. She was started on nasal cannula, 2 liter, but oxygen saturation was remained the same. So shifted to high flow nasal cannula, 100%, and that did not make any difference in the saturation. Further dip in the history, antenatal nothing. There is a positive consanguinity, 1st degree cousin. She had one of her siblings who died at 8 years of age, labeled atrial palsy, secondary to hypoxic ischemic encephalopathy. And other 2 sibling boys who are doing well, and they are at school. And physical examination, the baby was well looking, not a respiratory distress. There is no dysmorphic feature. Hair growth parameter all within normal. Her chest examination clear. Her cardiovascular examination also normal. Abdomen, other examination, neurological examination, everything was normal, within normal. So, sorry. You have a blue baby, and this is not unusual for in ICU. So we have a lot of differential diagnoses. It's called, number one, the fellow kept in their mind is cytotic congenital heart disease, could be any of like a TGA, tetralogy of Fallot, pulmonatresia, or respiratory, could be RDS, PPHN, because she born through meconium, still like pneumonia, or other structural respiratory problems. Could be metabolic, hypoglycemia, other important area of metabolism, neurological, and as any baby coming in ICU, one of the differential diagnoses is sepsis. So, what you will do for this baby? Full-term baby, 2 hours of age, cyanose, baby look normally well. Any suggestion? Any suggestion? Anyone? What you will do for this baby?
This one need admission first, and then we'll do chest X-ray and echo. If it's
Okay.
echo not available, at least we'll do CCHD.
Baby is born 4 in the morning. So first things, it's just X-ray. X-ray done, as you can see, really nothing significant can explain that. Lung look normal, heart size is normal, everything look normal, and this is a normal chest X-ray. So what you will do next?
Echo.
Echo. Before echo, blood gas. So this is her blood gas, 7.5, and BCO2 21, BO2 86, bicarb almost 17, base deficit 0.6. And this is on admission without oxygen. And after they start the baby on oxygen, of course, because the SATS was not improving, so they put that baby to 100% oxygen. And the gas done after almost half an hour, and you can see the gas, 7.5, BCO2 28, BO2 289, and base deficit bicarb almost 16, base deficit -3. They did, of course, a CPC hemoglobin 18. This is the baby hemoglobin, white cells 10, hematocrit 54, platelet was normal, and the cord gas show hemoglobin of 19.6, and the rest was normal. CRP negative. So what next? Okay, so echo was the next. So the fellow called the cardiology at 6 in the morning, and they came, and echo showed only small ASD. Blood culture, of course, taken, and baby started on antibiotic. So I came in the morning, and everybody was really, all the team around the baby. A baby sat 80s while in 100%, and echo normal, X-ray normal, CBC normal, everything is normal. So when I came like all our neonatologists. One of the special characteristics of neonatologists, they are smiling all the time. All the neonatologists. I never see a neonatology who's يعني مكشر دائما. So I came in the morning, but my fellows, they think me like this. I came with a bomb. So everybody's scared from me actually in the unit, resident staff. And I looked to the baby. The baby looked like this. This is not our baby, but similar to. Very comfortable baby, not in any respiratory distress. So what you should do?
Yeah. Excuse me, Dr. Jubara.
Yes.
In the blood gas, what is the methemoglobin?
Yes, this is what happened. So when I came, I told them, show me the blood gas, and you can see the methemoglobin was 28.
Yeah, so methemoglobin.
So we thought most probably this is a methemoglobinemia. But there is something. As neonatologists, we are looking for the details. This baby diagnosed as HIE, and she died with severe neurological disturbance. So I went back to the medical file, and baby born in one of the hospital referred to us to cardiology clinic. 5 weeks of age, and according to the note from the consultant, admitted because of cyanosis. Okay, improved, but she stayed, an echo done, and it showed ASD only. Baby was stay in the NICU for 10 days because of jaundice, require phototherapy. But you can see that the doctor noted the baby had a peripheral cyanosis during crying or during feeding. But she was thriving well at that time. Repeated echo done, and it was showing only ASD with left to right shunt. So they give her a follow-up. And this is the report of the echo in the birth hospital, were done on day 1 of life. So the baby most probably was cyanosed. That's why they called the cardiology at day 1 of life. So, and the same, it showed only ASD. Then baby seen at 4 months of age in the cardiology clinic for the follow-up of ASD. And the fellow reported there is an increasing tone in all limbs and more in the lower limbs, twisting of the hand bilaterally and scissoring. And the baby was not growing. She was failure to thrive. So what he did, evaluation for GERD and referred to neurology. And our colleagues in neurology, they like the word HIE. So they did an MRI, and MRI showed brain atrophy, and they labeled her from age of 6 months as CP secondary to HIE. I looked to the file. Myself, I went to medical report. I looked to all the file. Unfortunately, no blood gas done for this baby because she was following for failure to thrive in neurology. I found 2 blood gas at age of 7 years. And that showed the methemoglobin was 11 and showed 9.6. So most probably this baby is the same having methemoglobinemia. We looked for the other sibling. The other sibling was doing well according to the parent, and they are at school. And there is only following in the primary clinic because they don't have anything of concern. But those 2 babies born in our hospital, and part of our blood cord gas, we do the methemoglobin. And their methemoglobin 1.7 and 2.3. And that's above normal range. So we sent a target gene testing for this baby, and it confirmed autosomal recessive methemoglobinemia with novel, not reporting mutation in the cytochrome B5 reductase. And most probably, this is a type 2 because it involved neurological abnormality. So what we did for this baby, we give her immediately methylene blue. First of all, I consult our hematology, and the first thing they said, we never saw any case of methemoglobinemia, it's just in the exam. So we quickly review all the references and what we need to do for this baby. So methylene blue, 1 milligram per kg given, and within 10 minutes, the saturation increased to 100%, and the baby was pink. And we did a gas in 1 hour, and methemoglobin dropped from 29 to 2.8. Then we started also on ascorbic acid. We kept the baby 10 days in the hospital to see at what time the methemoglobin may be elevated. So about 10 days of life, her methemoglobin was more than 10. And from literature, we agreed this number we need to treat. So we give her methylene blue, and it dropped significantly to 1.2, and we discharge her. We bring her to the clinic in 10 days to see, and in these 10 days, almost the methemoglobin approaching the 10, and she required methylene blue because she was following in other hospital. She wants another city, so we refer her to our colleagues from Al-Qunfuda, and we give them advices, and we make sure the methylene blue is there. She requires several visits and several administration of methylene blue. We did, of course, hemoglobin electrophoresis, and which was reported as normal, and G6PD screening was normal for her. So this is a case of methemoglobinemia. We know it in the exams, we read about it, but unfortunately, it is undiagnosed in most of the cases. So congenital methemoglobinemia is a very rare cause of cyanosis in neonates. It is best described by increase the sustained concentration of extradized hemoglobin, and that either due to congenital change in the hemoglobin synthesis or functional deficiency in the enzymes, like what's happened in our baby, which is responsible for reducing methemoglobin in the normal erythrocyte. What is the normal? In general, anyone who did the methemoglobin, it should be less than 1%. So this is showing us, like, as you can see, the hemoglobin molecule is a tetramer, two molecules of 2 alpha and 2 beta. And each of a hemoglobin molecule will have 4 atoms of iron, which is a ferrous form. And that can reversely link to the hemoglobin and link to 1 molecule of oxygen. And that gives you a 4 molecule per 1 hemoglobin molecule. If there is a problem, like an enzymatic deficiency, like in a case of cytochrome B5 reductase mutation, or the commonest is during drug-induced methemoglobinemia, what's happened? The ionized form of hemoglobin, where the ferrous hemoglobin will exodize and it will go to the ferric. Okay, ferric iron. Ferric iron cannot bind to oxygen. So it will increase the oxygen, the affinity, and lifting the oxygen dissociation curve to the left. And that's what will happen, what will cause, that will affecting the release of oxygen, leading to tissue hypoxia. Other mechanism or other causes like abnormal hemoglobin. That's why we do hemoglobin electrophoresis in the babies or other causes to rule out other associated hemoglobin abnormalities. How common this? When I look to the literature, in 1845, a French physician described a patient who endorsed as a congenital cyanosis, and that baby had no any obvious cardiac or pulmonary dysfunction, so they call it congenital cyanosis. In 1940s, Gibson showed that in this patient there is a diminution in the ability of erythrocyte to reduce methemoglobin. In 1959, they identified the enzyme responsible for methemoglobinemia, which is the 5-alpha cytochrome B5-alpha reductase. How is the incidence? Really, the incidence is unknown, because most of these cases misdiagnosed or labeled as, for example, HIE, especially the one who will have type 2 with progressive neurological disorder, and they died early in life. So I found this portrait in 1982, and it's written blue-skinned Fouquet's family. So a family like lived in 1700 with a father called Martin. He was blue. Then he get married to a lady, which was supposed to be normal, and they have 3 kids who was blue, and they labeled them as the blue family. And there is a root of different pedigree for those without, of course, diagnosis, but they call them the Fouquet's family. So congenital methemoglobinemia is really underdiagnosed. When I looked to the literature, I could not really find any really detailed cases. So this is one of the report in 2017 in hematology journals by the American Society of Hematology, and they report only 11 cases. And these cases, if you can see, with very high level of hemoglobin, but actually most of them didn't have really an accurate diagnosis. So in some literature, it has been estimated 1 in 100,000 cases. But a paper from Russia, they reported 47 per 100,000 cases with high prevalence in that area. What about in our Kingdom of Saudi Arabia? I looked actually, I could not find any neonatal cases has been reported, except these cases by our colleagues, Dr. Manal, Jilwan, I think hematology from radiology, department. They reported a baby with hypoplastic basal ganglia. And when they do extensive workup for developmental delay, they found she had cytochrome B reductase deficiency, and that confirmed the diagnosis, but unfortunately the baby died. She had another one sibling with the same family, delivered in other hospital, referred to King Faisal Specialty Hospital because of the methemoglobin was 25, and they start immediately methylene blue, and follow up at 3 months. She presented with seizure, and MRI showed abnormalities, and genetic testing confirmed type 2 congenital methemoglobinemia. This is a case report also from Saudi Arabia, but they didn't have a genetic diagnosis. Is a 16 years old who presented with cyanosis. And when they did the methemoglobin, it was 27. It was high. And they did the cytochrome B5 reductase, and it was low, but no genetic testing. And the patient disappeared from the clinic, and there is no follow-up for that one. So this is the only reported, I found it in the Saudi Arabia. So the form, the commonest one, and you find a lot of report, is related to drug exposure. And this is an acquired, and presentation of cyanosis happen in most of the time in adults. And there is some cases of pediatrics. The type 1 methemoglobinemia, which is autosomal recessive disorder, presented all the time with cyanosis at birth. Type 2, the same gene, but the presentation the same as type 1, but unfortunately they have neurological involvement. And it's bad and poor prognosis, unfortunately. Type 5 or 4, very, very rare. I could not find except only one case report, and they presented with disorder of sexual differentiation and cyanosis at birth. Now, there is another like hemoglobin M disease and unstable hemoglobin, and those autosomal dominant disorder, and the gene identified, and the same they presented at birth with cyanosis. This is the commonest, and if you look to the literature, just if you put methemoglobinemia, what will happen is the acquired one, and there is 126 medication can cause methemoglobinemia, and this is can be treated most of the time easily. So the type 1, the problem is the functional deficiency of the cytochrome B5 reductase in RPCs. They have high methemoglobin and up to 40%, but the babies usually they adapt to high level by compensatory polycythemia, and usually they have normal life expectancy. Type 2, as I said, a rare one and severe form, and the deficiency in all types of cells. Life expectancy is short, and most of them, they will die in the infancy. Affected newborn usually presented with progressive neurological deterioration, mental retardation, developmental delay at early age, at 3 to 4 months of life. And this usually happen within the first few years of life.
2 minutes, Doctor.
So, 2 minutes, okay. So clinical presentation, it depends on the level of methemoglobin, less than 10, asymptomatic, and more than 10, cyanosis. For bigger or adults, they presented with headache, fatigue, dyspnea, lethargy. More than 70 is associated with high risk of mortality. How we can diagnose this? First of thing, you can have a quick bedside. The blood of babies with methemoglobinemia, it will be brown chocolate color, not red like other. And this is really what we notice when we extract blood. The blood look brown. So what you can do, you can put a 1 drop in filter paper and you can see the color. It will not change when exposed to oxygenated, to the room air. While the normal blood, it will be red color. Cytochrome B5 reductase activities is very important to establish the diagnosis, but in neonate, only 50 to 60% they have a normal adult level, and did not really till age of 12 months to have the adult range. And most of the lab, they didn't do it. So we were not able to do it. Even when we tried to send it to Germany, they said we didn't do that. So the genetic testing, I consider it the gold standard, and it should be done for all babies, especially if there is a family history. Hemoglobin electrophoresis is important to rule out the other abnormal hemoglobin, and G6PD screening is important. Management, if you look, there is really no recommendation at all what we need to do for those babies. And even the treatment will help or not, especially for type 2. So several factors depend on the patient symptoms, total amount of methemoglobin, the cause, and the patient age. And if you had additional compromising risk factor like congenital heart disease, lung disease, or significant anemia, the drug of choice is methylene blue, and it is a magic. Within minutes, you will see the response, and it can be repeated. The problem with it's contraindicated with baby with G6PD deficiency. And ascorbic acid, another one, can be used as adjuvant therapy. It's a strong reducing agent that take part in many oxidation reduction reaction. Nobody know what is the exact dose. A lot of doses has been reported and can be used if methylene blue is contraindicated. Hyperbaric oxygen used in adult, but there is no data for neonate. And exchange transfusion has been suggested, but again, there is no data for neonate. So in conclusion, congenital methemoglobinemia is a very rare condition. If you have a baby with a cyanosis without respiratory distress and no cardiac abnormality, it's methemoglobinemia till proof otherwise. In neonatal population, treatment should be started early, but due to limited compensatory capability in the first month, prognosis, it depends on the type. Type 2 is the bad, very poor prognosis, while type 1 is normal. And thank you very much.
Thank you, Dr. Jabara. Inclusive and detailed the presentation. Thank you. The next speaker in this session is one of our colleagues, friend from other department. But before he come to the podium, I want just to prepare for his lecture by saying that this lecture was supposed to be given by me. But I said, there is some better people from the legal point of view, they can, do better presentation and maybe put you in a better way of looking at this matter. The work we do as a neonatologist is very complex work. We are really dealing with very sick babies with, a lot of debate about viability, viable, not viable, what to do. So it's a lot of big questions that, usually we dealt with it in our clinical practice. And to treat, not to treat, to do C-section or just leave the baby in till, born as a stillborn, to do full support after birth or just to do comfort care. And if we start treatment, what we will do after.
Should we withhold, like, advanced treatment? Should we withdraw the treatment? So all these questions over years, and every presentation, every time we meet together, we try, to bring it up. But I think in my, simple and humble conclusion, that I think we need to communicate more with the obstetrician. Of course, as you know, they are the one who will handle those babies to us. Communication in prayer time, and and also to be involved more with the parents, to discuss with the parents, and not only to discuss with them before delivery or with acute incidents, what happened to the baby, to communicate with them on ongoing basis, what's going on, and to update them. And in spite of that, you will find some families, they still complain, and they will complain about you and said, you didn't do a good job. So I think the medical legal issue is there for a long time, but it may increase with what's going on in the society. It's a pleasure to present to you Dr. Abdulhamid Al-Saeed. Abdulhamid Al-Saeed graduated from King Saud University 1982, and he did his fellowship in anesthesia through the Royal College of Surgeons of Ireland. He's currently a professor of anesthesia and the chairman of the cardiac anesthesia division at King Fahd Center at King Saud University. He is the chairman of the Saudi Anesthetics Association from long time till now. So, and he's a consultant anesthetist in King Khalid. What is important in his career, he's an advisory consultant in Ministry of Health for the medical legal cases since 1998. And this is what make him, a good resource for a lot of medical legal cases that he saw during his career and participating in this committee. Dr. Abdulhamid, تفضل.
بسم الله الرحمن الرحيم. Thank you very much, Dr. Abdul Hakim. It's my pleasure to be with a neonatologist. I deal with the cases on neonates as an anesthetist, but today my talk will be about medical legal aspect, because none of us is immune against medical legal. Any parents can, as Dr. Abdul Hakim says, can complain against you. So this lecture is, I hope, in 15 minutes, just show you, as you can see from the past history, even the people at the back here are waiting with the papers. They are medical legal people, waiting for any mistake to happen. Let's talk about the scope of the problem. We have upgrading technology, as Dr. the one before me mentioned, that is a lot of technology coming. A lot of people coming from abroad, training with experienced medical staff. But the same thing, the population since it started, the social media become very awareness of about the health matter is very important. This is some of the upgrade in the hospital. This is robotic surgery in cardiac surgery. So there is a lot of development, but at the same time, thank you very much. At the same time, you will find in the social media or in the newspaper like this cartoon. أبداً والله كل اللي حصل مجرد أخطاء طبية بسيطة. So the people will get that the people in the hospital coming to make a mistake. Or like this one, الصحة تناست القضية ولدها في حيرة تخدير انتشار طفلة رهف الطبيب هرب إلى بلادي دون حساب. Big picture in the newspaper, people will get worried about their children and their patient. This is one of the newspaper. الرياض أصدرت الهيئة الطبية الشرعية منطقة تأسيس وحكم بتغيير طبيبين مستشفى خميس مشيط 120,000 ريال تسببوا في غيبوبة مريضة لمدة عامين. Like this newspaper, like this خطأ طبي يؤدي لقطع لسان طفلة وآخر يرمي أخاها. عفوا. Like this picture, they put this. الخطأ الطبي حرم خالد وأحمد وريناد من ولدتهم. Her mother died, so they put the picture of the people that. So to handle the problem, the medical legal committee, they formulate standard and regulation related between the facility and the physician towards the patient. And this was increased by royal decree 1409 هجرية. From that time, it's becoming responsible, the term responsibility of medical practitioner, regulate the patient-doctor relationship. So anybody cannot go and fight with the doctor in the hospital. You have to go through the medical legal committee. The members of medical legal committee usually is the judge, which is assigned by the Ministry of Justice. Is what we call فئة ألف, قاضي فئة ألف, and doctors from 2 members. We meet every week. As you can see, this is the judge and the papers of the file of the patient in front of him. Okay. So this is the guy is a legal advisor. He's a urologist. The next one to him, and then general surgeon, and then me, and then the judge. In the other side of the table is the people who are complained against. They're talking, and legal committee. We have the rule. It's responsibility of the receiving claims, investigation, professional malpractice, and relate either morbidity or mortality. Number of the 8 subcommittees is becoming now more and more. I heard the last development that's become through the Mahkam al-Shar'iyya. You have to go to the Mahkam al-Shar'iyya, but we used to be in the. So what's the process usually? The claim from the patient was his representative towards the medical practice from his view that it's a mistake happened. Claim directed either to Ministry of Health or city government. Investigation starts immediately within the medical facility. It will take time, but usually the file will be stopped, will be kept in secret places, and investigation through the hospital. The medical legal committee assigned then to follow the process through the, and then they will reach to the final decision, which is according to the Sharia medical practice, Islamic Sharia. So for the female, and don't get angry from me, usually بالنسبة للدية الشرعية نصف دية الرجل. This is just some professional civil liability, مسؤولية المدنية, punitive liability, مسؤولية تأديبية. مسؤولية المدنية is the responsibility of the physician towards the patient when harm being inflicted as a result of direct. يعني إذا حصل شيء للطفل أو للمريض هذا تعتبر مسؤولية مدنية. المسؤولية الجزائية physician who violate the rules and regulation of the medical practice even with no subsequent harm result. والمسؤولية التأديبية when physician fail to meet the professional requirement of ethics بدون ترخيص من الهيئة السعودية الصحية الشرعية. The final decision will reach in the committee either clearance from the claim, and this most of the cases, or warning to the doctor, financial compensation to give to the patient relatives, or prohibit the doctors from medical practice, medical license withdrawal, and we can put the doctors in the prison. This has never happened, alhamdulillah, so far. This is some studies which I did it in 5 years, just to show you how and it's published in your King Faisal journal. The aim of the work is to study the period of the analysis, medical specialty, which have the more medical mistakes, and sector of the healthcare facilities, and geographical distribution of the care. And as you can see by the years, it's becoming more and more claim. As I said, upgrading hospitals, same times people with the social media, they are becoming very familiar with the newspaper, with the Twitters. They can simply just mention the accident and you will find it spread all over. I found from my study that most of the cases is obstetric and then the last one is dentist. Obstetric, I think, because of the mother and the baby. If the mother is safe, the baby may be not saved. So that's why the obstetric is more. Percentage of the trend malpractice, total number, as you can see in 1420 was the highest, then it became less and less. But this is just to show you how distribution of medical health care service. Ministry of Health, most of the cases happen with it. In 1424 was 188 compared to other medical services, because this does not blame Ministry of Health, but because most of the Ministry of Health care about 90% of the health care in this country, where National Guard is only for the National Guard, university only for the university, security only for the security. So private only, military for, so that's why Ministry of Health does not mean it's bad, but because it is mostly of the cases happen in Riyadh, then Makkah al-Mukarramah, then Eastern region, then Medina Munawwara, then Asfir, Qasim. Ihsa was, subhanallah. Just to give you some example, which Dr. Abdul Hakim said, I'm an anesthetist, which is anesthesia-related malpractice. Just to show you some example. This is morbidly obese patient was coming for elective gastric bypass surgery. No concurrent illness, preoperative fasting for 16 hours, proper medicated, and then aspiration prophylaxis was given. But the anesthetist did the mistake that he used a long-acting muscle relaxant to start. In this case, it should be rapid sequence in order to protect the airway. So he used cisatricorium. He first attempt endotracheal tube, then 15-minute refractory hypoxemia. He postponed the surgery, transferred the patient to ICU. He had multi-organ failure, and then mortality followed up. The anesthetist was accused of not being following the medical standard of not using short-acting muscle relaxant during the intubation, especially for the obese patient. The other case, this is a female, para 11, for emergency cesarean section, pre-presentation. There was a lot of hemorrhage intraoperatively. No blood was available. 6 hours post-operatively, mortality follows this lady. And the husband, of course, get another wife. The anesthetist shares responsibility with the obstetrician for not checking the blood availability, or even reserving and no intraoperative anesthesia record of management. The last case, diabetic patient for emergency perianal abscess evacuation. Preoperative blood sugar was 235 milligram, and then they started her on insulin. The surgery was very minor and eventual, continuous and normal saline postoperatively. They never checked. The patient started to have disturbed consciousness, severe hypoglycemia, cardiorespiratory arrest, and mortality for 5 days in the ICU. So the anesthetist was accused not following the standard medical practice for checking the blood sugar postoperatively. So from 15 years in this medical legal, the recommendation, which is a home message for all of you, As you can see, there's no minor anesthesia because I'm an anesthetist. Also for you, there's no minor neonates. Always should be. Assess your patient thoroughly. Ask for advice in case you need. One of the cases happened that the anesthetist was نافخ صدره شوية. قال له, I don't need the help. I'm a consultant and I will call another consultant. What's the point? So if you are in trouble, call for somebody help, for another opinion. Share the patient and relative plan of treatment. Always very, very important. Most of the cases, the patient does not find the doctors to talk to him of what's happening to his child or what's happening to the patient. So it's very important for you. Estimate the accuracy and discuss with the patient. Always make clear consent, informed consent, and clear documentation of every detail, date, time, very important. Most of the doctors who was cleared from a complaint because they have record and date and time, they have explained to the patient what happened to him. Encourage your education activities by attending like these meetings. Update your professional knowledge. In case happened to you an incident, as I mentioned at the beginning, none of us is immune. Review the case, filling records, quote relevant literature, provide testimony in writing, and don't fight with the people in the judge, in the court. Fighting means that you are not trustable. This is my opinion, I think. We'll have it. So be quiet, writing everything in document. When you are certain of consequences and error disaster, so it's logic to be too careful. No one is immune against mischief, and we pray for Allah to provide us. This is from Iraq picture. This all children is being killed by American terrorists. To whom they should complain? I mean, when you have a mistake in the hospital, they will go and complain against you as a doctor. But these children, whom they should complain. Thank you very much, Dr. Abdul.
شكرا دكتور عبد الحميد. I'm sure you have a lot of questions in your mind about how this committee, the medical legal committee of the Ministry of Health work. And we will have open discussion with Dr. Abdul Hamid after we finish this session. We have one more lecture in the session. Dr. Abbas Al-Amran, who is a consultant neonatologist in Al-Mana General Hospital, Al-Hassa Al-Hafuf. He's graduated from King Faisal Dammam, 1987, Arab Board in Pediatrics and Fellowship at King Faisal. And Abbas will know for his activity and interest in the bilirubin. He will talk to you about red flag and hyperbilirubinemia. تفضل Abbas.
Thank you very much. Just give me a minute, please. بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا ونبينا محمد وعلى آله الطيبين الطاهرين وأصحابه المنتجبين. Good morning, everybody. Thanks for the organizing committee for inviting me to give this presentation. Actually, the title was Red Flags on Indirect Hyperbilirubinemia. But it happened that the American Academy of Pediatrics published an update on their guidelines on last September, 2 months ago. So I elected to put them both together, the update and the red flags together. I'll start with this case. This is a tragedy that happened like 10 years ago. And I think it's still happening. This baby was born at 39 weeks with appropriate for gestational age weight, and the mother was healthy, gravida 2, para 1, 32 years old. And the baby was discharged as a normal baby at 25 hours. And if you look in here at the picture of the graph here, I can use the pointer. Our protocol in nursery that we check the bilirubin every 8 hours. We screen the babies for jaundice. And actually we assume that babies are G6PD deficient. Even before we have the results, because we have high incidence of G6PD deficiency. So that's why the red color, the yellow color pointing that this baby is having risk factor that is assuming to be G6PD deficiency. So the baby was discharged and came back after 4 days to the OBD at around 100 hours of age. And I admitted the baby in the evening. That was around 8 o'clock in my evening clinic. And I advised for starting intensive phototherapy, and I went home. Next day I came in the morning, 8 o'clock, asking about the baby, and they told me the baby disappeared. After admission, they checked the bilirubin. It was 340, and then the father received a call from his mother, the grandmother of the baby, saying that this is simple hyperbilirubinemia or jaundice that can be treated at home. So he signed against medical advice, and our residents, he did not object, so he discharged the baby. And I called the father, and I told him that you have to bring the baby. The baby needs phototherapy immediately, but he was at work. He didn't come back till around midnight when the baby refused to feed. Baby is not feeding anymore, so they brought the baby. And unfortunately, the baby was in a bad shape. The bilirubin was 686 micromole, that's 40 milligram per deciliter. We exchanged the baby, but the end result was this baby after 2.5 years. If you look at this baby, look at him, he has chorioathetic movements. Look, if you look at his teeth also, he was not hearing well. So this is a case of kernicterus. So what we did in the unit, I think we did good things, that we are monitoring the transcutaneous bilirubin for every baby, and we screen for the risk factors, including the blood grouping and the G6PD at that time, and we gave follow-up. The patient came on follow-up, and we encourage breastfeeding. We educate parents. We give them materials about jaundice and G6PD deficiency and breastfeeding. And I admitted the baby on time, I think, but the problem happened. If you look at the curve again backwards, you see that we did transcutaneous bilirubin, and it was low in the first 24 hours, so it did not help us in the screening, actually. So this baby had G6PD deficiency. We had the results later on, but we identify him as G6PD. We readmitted the baby, but unfortunately, our doctor allowed the baby to go home, even against medical advice. That's why we need to educate our medical staff, our residents, junior doctors, and we have to educate also the parents. And we lost this baby on follow-up. I needed to call him to video him again. So actually, we don't know what is the incidence of this issue of severe or critical hyperbilirubinemia and bilirubin-induced neurotoxicity or kernicterus in our country, and what are the measures that we are taking to reduce this problem. We have to work on this, as it's stated this morning and yesterday. A quick review on jaundice. As everybody knows, that jaundice is very common, especially in our place. Most of the cases, they end up in benign outcome, but some of them, like 10%, they develop severe hyperbilirubinemia, they need treatment. And in 2016, there was 1,309 deaths per 100,000 live births because of jaundice. And it's ranked the 7th globally among all causes of neonatal death in the first week. So it's a global problem. It's not only happening in our country. This is a quick review on the metabolism, production, and elimination of jaundice. We need to understand that being jaundice is the outcome of increased production and decreased elimination in these babies. Classification of jaundice, I think it's important so that we talk about the same thing, but if you see severe jaundice, it's labeled as if the bilirubin is exceeding 20 milligram, and extreme is if it is beyond 25 milligram, and hazardous or critical if it is 30 milligram or more. The acute bilirubin encephalopathy is a syndrome that occurs in the first 14 days, usually with the neurological symptoms in association with critical level of hyperbilirubinemia, and it can be divided into mild, moderate, or severe. And if you see here, it can reach to irreversible stage once the bilirubin is at like 25 milligram or more, depending on the postnatal age and the gestational age. The chronic sequelae of acute bilirubin encephalopathy is the syndrome that's labeled as kernicterus, although kernicterus is actually a pathological description, but the syndrome is composed of 4 items. That's chorioathetoid cerebral palsy, high-frequency central neural hearing loss, palsy with vertical gaze, dental animal hypoplasia, and characteristic findings on the MRI. Whereas the histopathology shows usually deep yellow staining of the neurons together with neuronal necrosis, particularly in the basal ganglia and the brain stem. Why are we seeing still kernicterus with all the advantage? This is really a red flag that we still see these cases. It's worldwide, but why? Mostly because babies are discharged very early without watching them carefully, and there's no post-discharge follow-up in most of the hospital. Actually, this is one major point that we have to tackle in these conferences. Poor maternal education, inadequate breastfeeding, and hemolytic diseases, particularly G6PD in our place. But overall, Maisels, who is a bilirubinologist, mentioned in one of his articles in 2015 that failure of clinicians to follow the guidelines accounts for most cases of kernicterus. Like they don't worry about the level of bilirubin, they check it by their eyes, they don't ask for serum bilirubin. If you see this picture also, the baby is trying to say, exchange me, I have critical hyperbilirubinemia, but sometimes our physicians, they take it easy. And this is the registry of the United States of cases of bilirubin between 1992 and 2004. You can see it's increasing. I hope we can find or make a registry like this in our country. So what is our goal of treatment? Our goal is to prevent kernicterus. So our goal also is to decrease or keep the bilirubin below the exchange level that induce or what induced the neurotoxicity. And hospitals, they have to have policies to give the necessary care to minimize the risk of kernicterus. These are the guidelines that we have been using over the last 15 years, I guess since 2004, published by the American Academy of Pediatrics. On the left is the phototherapy thresholds, and on the right is the exchange blood transfusion. I found them easy to use and very useful. But there are some changes in the 2022 issue. In 2009, they made some clarification. They divide the risk factors as hyperbilirubinemia risk factors, factors that increase the production of hyperbilirubin, and hyperbilirubinemia neurotoxicity risk factors, which I'm going to tell you about later on. And after applying these guidelines, actually, the hazardous hyperbilirubinemia level incidence decreased because of two issues: the universal pre-discharge bilirubin screening and the closer post-discharge follow-up. This is the article published in September 2022, and it stated clearly here that the committee recommends caution and incorporation of local expertise in adapting these guidelines for use outside the USA. So generally we use their guidelines, but we have to have our own depending on our experience and patient type. These are the risk factors for developing significant hyperbilirubinemia. I think it is all known to you: low gestational age, early jaundice, pre-discharge bilirubin. It's a must. You have to check the bilirubin before discharging a baby if it is approaching the threshold, and hemolysis from any cause. Okay, whether it is known or suspected. Like in our patient, we suspect it to be G6PD. We assume every baby to have G6PD deficiency. If the baby received phototherapy before discharge, parents or sibling had phototherapy before, family history of inherited RBC disorders, particularly G6PD deficiency, and suboptimal exclusive breastfeeding, especially in primary mothers. You need to support their breastfeeding. If there is scalp hematomas or bruising. And how do we decide about the need for treatment? It will depend on the gestation as well as the age specific, our specific total serum bilirubin level or the transcutaneous bilirubin, but usually before starting phototherapy, we do serum bilirubin, and the presence or absence of risk factors for bilirubin neurotoxicity. These are the hyperbilirubinemia neurotoxicity risk factors that includes, again, premature babies less than 38 weeks. Even 37 weeks is considered not a premature baby, but a risk factor for developing severe hyperbilirubinemia and neurotoxicity. The presence of isoimmune hemolytic disease, hemolytic disorders, particularly again G6PD deficiency, and hypoalbuminemia, presence of abscess, acidemia, or clinical instability within the last 24 hours. Red flag in here about G6PD deficiency, الفول وما أدراك ما الفول. G6PD deficiency is the most important cause of hazardous hyperbilirubinemia, leading to kernicterus everywhere, not only in our country, even in America and other countries. G6PD is the leading cause for hyperbilirubinemia associated with kernicterus. These infants are more likely to receive phototherapy before discharge. They are at greater risk of readmission. If you see a baby who is formula fed, exclusive formula, and then he develops severe hyperbilirubinemia, think of G6PD deficiency. Some of them, they don't have positive family history, okay, or maybe the parents, they don't know about it. Sudden and extreme increase in total serum bilirubin is another cause. That happened to our patient, if you remember. Suddenly the bilirubin increase. And there may be little or no laboratory evidence of hemolysis. Usually the retics are normal. So that brings us to the conclusion here that neonatal screening for G6PD deficiency is a must, particularly in our area. It's an X-linked recessive disease affecting around 400 million people worldwide. If you look at the incidence here in the Arab countries, I think we had SAP here, we have the highest number reporting up to 40% G6PD deficiency. And compared to Bahrain, 18, and Oman in the Gulf area, I think up to 29. So we have the highest incidence of G6PD deficiency in the region. This is a study done by Professor Al-Hazmi showing that the Eastern province carries the highest frequency of G6PD deficiency genes, especially in Qatif and Al-Ahsa area. And this is a study published in, I think in 1992 or so, done by Professor Abu Asba and his group. And they screened 34,000 newborn in Dhahran Aramco Hospital, and they found 18.4% of these babies were G6PD deficient. 42 of these babies required exchange transfusion, but none of them developed kernicterus compared to the period prior to the study where they have 7 cases of kernicterus. And they come out with a conclusion again that neonatal screening for G6PD deficiency and comprehensive education program is advisable. We reviewed the causes of jaundice in our hospital, King Fahd Hospital, before 1999. And the same finding also, we reached that 30% of our readmitted babies for jaundice were G6PD deficiency. And we came out with the same conclusion and recommendation that cord blood G6PD screening is a must. And we repeated the study later on. I think we published this in 2017. Again, around 40% of our readmitted babies were G6PD deficient. And again, we recommended G6PD screening. Visual estimation of bilirubin concentration. The American Academy recommends that you screen the babies visually, or it's better to be done by transcutaneous at least every 12 hours. What we do in our unit, we screen them by transcutaneous bilirubin every 8 hours. And the total bilirubin, serum bilirubin, should be measured as soon as possible for infants noted to be jaundice or transcutaneous bilirubin. And those who are appearing jaundice in the first 24 hours, particularly at higher risk of developing significant hyperbilirubinemia. But visual assessment does not replace the need for obtaining at least one reading by transcutaneous bilirubin or serum bilirubin before discharge. That is the recommendation. The transcutaneous bilirubin measurements are valid and reliable, and to reduce all of blood sampling and reduce the rate of having significant or critical hyperbilirubinemia. And this can be done in nursery as well as the OPD during the visits. But we need to check the serum bilirubin if the transcutaneous bilirubin reading is within 3 milligram per deciliter of the phototherapy threshold, or if it is exceeding 15 milligram per deciliter. And if the baby received phototherapy, usually transcutaneous bilirubin is not valid until 24 hours after stopping phototherapy. You can calculate also the rate of increase to give you an idea of the rate of hemolysis if they are. Post-nursery discharge is follow-up is a must. This is a very important item that we need to really emphasize it. And I like to repeat what Egret wrote once in 1998, that post-discharge services are more important to assure good outcomes than the precise time of discharge. So whether the baby is kept for 24 hours or 48 hours or more, you still need to see these babies after discharge. If you cannot guarantee post-discharge follow-up, then maybe the baby can be staying in the hospital for close monitoring. Usually, once the spontaneous bilirubin comes down, it does not increase. So if you saw the baby at 1 week and the bilirubin is already down, you don't worry about it.
Abbas, we'll give you 2 more minutes.
Give me more, please.
That will conclude. Huh?
Timing follow-up, before we use this curve in the upper right, but this is called botany nomogram, but it's no more recommended. The American Academy of Pediatrics recommends that you calculate the difference between the transcutaneous bilirubin or the serum bilirubin on discharge and the level of phototherapy, and according to the table, you decide the timing of follow-up and the type of follow-up. Prolonged indirect hyperbilirubinemia. This is if the infant is 7 days or more and his bilirubin is within 2 milligrams of the phototherapy threshold. This is usually associated with breast milk, and you can use home phototherapy for these babies if they are not exceeding the phototherapy threshold. But you have to consider cholestasis in babies who have prolonged jaundice defined by breastfeeders who are still jaundice at 3 to 4 weeks of age, or on formula feed of those who are 2 weeks or more. And the new definition for direct bilirubinemia or cholestasis is when the direct bilirubin exceeds 1 milligram, regardless of the percentage, whether it is 20% or more. 20% is no longer regarded as necessary. Phototherapy, we need to use phototherapy as intensive phototherapy, and the cylinder phototherapy is the preferred method of administering phototherapy nowadays. No one, I think, use the ordinary single phototherapy anymore, or double phototherapy. There are 3 points here that the technical reports advise that they say that there are new evidence indicating that neurotoxicity does not occur until bilirubin levels are well above the 2004 thresholds. And systemic review of phototherapy associated adverse effects found limited or inconsistent evidence of late adverse effects that includes cancer or epilepsy. And IVIG immunoglobulin has unclear benefits for preventing exchange blood transfusion in isoimmune hemolytic disease. This is the phototherapy threshold guidelines using different gestational age according to the gestational age of the baby. And there are 2 curves now. When there is no hyperbilirubinemia neurotoxicity risk factor, and the other one for hyperbilirubinemia neurotoxicity risk factor. So things are getting more straightforward, but it's also you are using 2 curves rather than 1 curve. The previous ones we are using 1 curve for all babies. Now that's different. I think it's easier to use the first one, but particularly this one has different gestational age from 35 to 40 weeks. So maybe it's a better curve, but I'm concerned about the level of starting phototherapy really. Home phototherapy is not possible in here. Sun exposure is not advised. Please don't advise babies to be exposed to sun. We have to encourage breastfeeding, and we don't interrupt phototherapy. I mean, interruption of phototherapy is not a problem unless the bilirubin is really reaching the exchange. You have to screen them for a cause of jaundice. And when to discontinue phototherapy is very important. I think this is the first time they touch on this. Usually phototherapy We started and then we watched the bilirubin falling down, but they advise if the bilirubin is 2 milligram below the threshold, you can discontinue phototherapy. Rebound phototherapy occurs a different percentage according to the cause, but G6PD deficiency again is the main cause of rebound phototherapy.
1 minute, Abbas, to finish.
Phototherapy follow-up, you have to follow them up and check the bilirubin within 12 or 24 hours if possible, otherwise later on. This is a new phrase that they are using, escalation of care, rather than they used before crash management. Now they use escalation of care. That is the care provided for those babies approaching the exchange level when the bilirubin around 2 milligram below the exchange level. So this is considered an emergency. You have to admit these babies to the NICU, and if you cannot do exchange transfusion, transfer the baby immediately on phototherapy and IV hydration. These are the new curves used for exchange transfusion, and it's available free online. And you can use also the bilirubin albumin ratio. Immunoglobulin can be used, they say, if you are approaching the exchange level within 2 milligram. This is a new item that I think maybe inshallah in the future will be possible, that they put a patch on the forehead and check and they have monitoring, continuous monitoring of the bilirubin together with the heart rate and SpO2. In conclusion, severe indirect hyperbilirubinemia remains a life-threatening condition, and delaying the diagnosis and management is the major contribution factor for morbidity and mortality. Promote breastfeeding, please. Educate parents and physicians. Hospital policies has to tackle this problem to prevent kernicterus. We have to have our own guidelines. We have to have our G6PD screening, and we have to start registering cases of kernicterus. And again, we have to have post-discharge follow-up. Thank you very much.
ثانك يو عباس. شوي ونطلب لك السكيورتي بس عاد كويس. خلصت الحمد لله. حفظك الله. تسلم. Okay. Can we have the speakers here on the podium? Please. So we have some time for discussion. And if you have any questions, put your hand up. Introduce yourself. Professor Khalid Al-Falih, let's start. And I will introduce you. طيب. تفضل بروفيسور.
يعطيك العافية. شكرا جزيلا. Thank you so much for all the speakers for very enlightening presentations. And I have a comment regarding jaundice. I think severe jaundice and kernicterus should be a priority for the Saudi Neonatology Society guidelines and policy development in the near future. This should be addressed immediately, and we should look after this problem as soon as possible, because it is a big problem. It is common, and kernicterus is 100% preventable, as we all know. My questions to the speakers and to anyone who knows. We in the private practice, regardless of the hyperbilirubinemia, we face a lot of parents making decisions on behalf of their babies to go home against medical advice, which put their babies at risks of complications either at home or just because of lack of medical care to their babies. Are you aware of any laws in Saudi Arabia that can protect those babies from the wrongful decisions of their parents? And if not, can we ask the Saudi Neonatology Society to communicate with the Saudi Human Rights Commission to develop such a law to prevent parents from making the decision to go home against medical advice? Thank you so much.
For this question, any volunteer to answer?
I don't have an answer.
Yeah, but try to have a short comment about the comment of Professor.
Definitely, we have faced a great problem, as you mentioned, and I demonstrated the case. We lost this baby because of the parents or the grandparents. So we have to have something against this. But I think also we have contributing part. I mean, if a physician sat with the parents and explained to them fully what are the consequences, maybe they will change their minds.
Maybe I comment on that. I do it in a different way. Like there is no discharge against medical advice for nursery at all in our hospital. And if we are like calling the social worker, calling the patient relation. Number two, if they are insisting, we ask them to go to نقول لهم روحوا الشرطة وجيبوا أمر بأخذ الطفل. I did that for 5 patients and all of them, they said, okay, keep him. So I think, jaundice, as you mentioned, it's a very bad actually, and it's affecting a normal babies. So we need to work very hard, have a consensus about discharge against medical, maybe other problem like follow up for something else, يعني borderline, but jaundice, we should take it very, very seriously. Maybe for a recommendation from the society about jaundice management as a recommendation, I mean, out of the meeting, توصيات تخرج من الاجتماع, how to deal with jaundice and the recommendation. Number 2, we did very excellent things, which is creating a jaundice clinic every day, even the weekend. Any baby discharged from normal nursery, he will come 24, 48 hours according to the risk and according to the graph. And it's surprisingly, even low risk baby, they come within 48 hours with high bilirubin require phototherapy. Alhamdulillah, like more than 10 years, we are creating this clinic. We didn't have any exchange transfusion. But keep in mind, even low risk baby, they may come with really high jaundice in the intensive photo.
Excellent. طيب. تفضلوا. دكتور سعد. Professor Saad.
I just comment on what Prof. Khalid Al-Falih said. Is really discharge against medical advice is a problem. And unfortunately, most of the hospital, they have guidelines for discharge against medical advice, but general does not address discharge against medical advice for the minor, like our babies, except few hospitals. I think I agree with Prof. Al-Falih that we need to address that, either we as a society or through what they call the Saudi Council of Majlis Saudi.
Professor Saad, can we hear from Professor Abdul Hamid about what happened, like, if some case like came with this signature of the family that they signed against medical advice and something wrong went to the patient.
في الحالة هذه ما يتحمل الطبيب أي خطأ. إذا كتب البيرنتس إنه موافق على خروجه وبتحمل الخطورة، القاضي دائما مع الحق يعني ما.
So it's part of the legality that, if we signed, then this is their responsibility. But our colleague here, they want to be advocating for the patient themselves, the right of those patients. I think it's worth it, to discuss it and see if we can bring it up to a higher level about what to do.
Yeah, I think the aim is to protect the babies. It's not to protect also the physician. They can't sign and go, but our aim is to protect the babies. The signature is not.
Of course.
The other thing may be the involvement, the SCAN team, the child abuse and neglect in the hospital. If any parent came for discharge against medical advice, especially in jaundice, involve that team. Each hospital in Ministry of Health, and they have that team. I think involve them, it will make a difference also.
دكتور عبد الحكيم، في قانون الحماية من العنف والإهمال الأسري 2013 وفي تجديد له 2017 under medical abuse. يعني لابد كل مستشفى يكون في كوميتي والكوميتي هي اللي تتحكم في هذا الشيء. No drama in my hospital. No.
Excellent.
Excuse me, I have,
So maybe Khalid, we can benefit from your experience if the society want to tackle this issue in the near future, inshallah. Any other topic?
Yes.
To go. تفضلي دكتورة.
Thank you very much for this very important question. Actually, I noticed if we give adequate explanation for the family, and it is from, for example, from the consultant himself, and we give full explanation, we'll minimize the patient number who are really refusing to have stay in hospital, and just to know what is the reason behind their request to go against medical advice. Maybe the mother, she has some issue, maybe she is sick, maybe they have a social problem. So if we are flexible with them and we'll tell them, for example, she can go out on pass and come back, and we give some options for her, so the baby will have a checking of his TSP again, for example, or will allow him to stay in the nursery with without watcher. So this can help.
Excellent.
Sometimes.
So you are suggesting some other solution rather than to
yes,
be
plus the
like,
child
to
protection
report.
team
Thank
to
you.
be aware of this case, to send the social worker and from hospital administration, so they will feel that it is a big issue and they will not do this disaster for their baby. Thank you very much.
Professor Saleh.
Thank you very much, Dr. Abbas, for excellent overview. The topic is very important and we all agree, but there are some problems. I think we can work on them and solve them. And I agree with Dr. Khalid regarding the role of the Saudi Neonatology Society in developing guidelines for this important, topic, especially nowadays. We see some changes, new recommendations, and personally, I'm not sure what other hospitals, what other pediatricians or neonatologists in other hospitals, how do they manage such cases, or how do they prevent it if they don't have clear guidelines? And I think this is one of the important things. If there's any recommendation for this meeting, is to come up with new guidelines for the jaundice.
Very
Thank
important. Thank you, Professor Saleh.
Okay, can I comment, Dr. Abdul Hakim?
اتفضل دكتور.
Okay. First of all, actually, all our topic today is very interesting, and most of them have medical-legal issues. If we start from the end, like Dr. Abbas, first of all, I noticed that this baby bilirubin, when he came around 600 something, right?
Yeah.
So for me, I would proceed for exchange right away, rather than intensive phototherapy. Maybe this will make the family will accept. I mean, phototherapy not expected to drop it significantly down. Second point, comparing the old nice guideline or phototherapy versus the new American, which is a little bit confusing sometimes. They start phototherapy based on the threshold rather than phototherapy or exchange and so on. Like there are 4 charts for the hyperbili, while in the NICE only 1 chart. It contains everything. When I compare the 2 groups, very much similar. There's no much difference actually.
That's why I said that we have to have our own to review these guidelines and reach to a conclusion on one of them. As I mentioned also, I was comfortable with the previous guidelines. I think the threshold of the previous one is good for our place also, rather than to increase it. Regarding the 600 micromole level, actually, when the baby first time was admitted, the bilirubin was 340, and that's the time when we did the phototherapy. But the next day when he came again, the bilirubin was 600.
600.
We went ahead and exchanged the baby, but the baby was symptomatic already.
Okay, thank you, Abbas. Can we shift gear a little bit towards the medical-legal issues? Because I think Abdul Hamid here, I'm interested to ask you, Abdul Hamid, about, when there is a medical-legal issues, if there is the service or the doctors are insured, where is the insurance company come? Are they coming, instead of him, they are doing the job of defending him? What they do? Are they doing any part in this?
The insurance company usually will protect the doctors لأنه من يوم ما تصير قضية على دكتور يمنع من السفر. فالانشورنس يسووا كفالة غرم وأداء.
So they release him from being prevented from traveling. But what about the real case? Can they defend him, in the court? Because they are paying money. And I know some hospitals here in Riyadh, they are insuring all their doctors.
Usually the judge, they ask for the doctor himself to come. They don't rely on the muhami or the insurance company. The doctor himself should come to present himself.
Can I make a comment in this regard? We are insured in my hospital. Everybody is insured. I mean, all physicians. But there are legal department also. But when we go for investigations or to the judge, we go ourselves. But then there is insurance already. You will not pay money. You are not going to pay anything. And the legal, they usually also.
But this is upside down insurance. Why they are insuring us? So if we will defend ourselves.
No, we have to go for investigation. You have to go.
That's part of the investigation.
Yes. How will the judge decide? You have to ask your questions.
Many times they are reporting the mistakes of the physician. On the other side, there are tons of physicians have been complained in the newspaper, and they are not guilty, and there is nothing done compensated for them, or protected. So the people, they are always looking to the bad side of the physician, but never look for when they complain. There is nothing wrong from his side.
So to advise the doctors who think that this is دعوة بقول not legal for him, he can go to the Amara and complain against the to the parents who complained against him or to the patient. Not the اعتبار.
He need a leave to do that.
But I think also when you write a complaint or when they write a complaint, there is an issue there. They say if this complaint is false or so, you're going to suffer. إذا كانت شكوى كيدية أنت بتحاكم أو شيء من هالقبيل. أنا ما كنت في لجنة المخالفات كانوا الأهل يوقعوا هذه الورقة.
Excellent. We should have some other questions here on the top. Sorry.
أنا have comment.
خالد ما تتدخل إلا لما نعطيك الفرصة.
طيب أنا رافع يدي أهو.
طيب أنا عارف بس استني شوي. طيب. في هنا يد ثاني مرفوع. تفضلي.
بسم الله الرحمن الرحيم. السلام عليكم. I am Dr. Jubaira Abuat from Abha Maternity and Children Hospital. I'm working under the umbrella of Dr. Mufara Asiri. I believe with Dr. Jubara, Lama should not be allowed in these intensive care units because it is very risky. As worker in that maternity hospital, I am the frontliner in the postnatal, antenatal. I'm the one assessing for this jaundice, and we struggle about the parents like this. For me, I'm telling them, if jaundice goes too much high, your baby will go connectorous. Then they will change their mind. My question.
Yeah.
Does this Lama paper protect us? Does our responsibility stops there? Of which my conscience, I don't stop there at the Lama paper. Is this acceptable in the court?
Will
this protect us?
It has been said clearly by Professor Abdul Hamid that if you sign this paper against medical advice, you are clear from legal point. It should be fine, but we are talking about our responsibility as a doctor different way. Any other thing, Dr. Majid?
Thank you.
We will come back to you, Khalid.
I think to start with, at least that we should not allow the resident to accept parents signing without informing the consultant on call. I think the consultant on call should be informed if this is going to happen. And maybe if he comes, I agree with the doctor, I think most of them, at least during my years in Saudi Arabia, can be resolved by the consultant with the proper talking.
If the consultant here, Majid, is available, many of them are not available. But anyway,
لا بس
Khalid, we go back to Khalid.
another comment for the resident. I think resident should not discharge baby from nursery. We allow only the senior or assistant consultant who do a discharge for baby. No resident allowed to discharge. They can examine but not discharge.
Can I make a comment? After this incident, Dr. Majid, he said what has been done already, that residents not allowed to discharge Lama. And there's a policy that the consultant, if he's not available, he needs to be called and talk to parents and the social work. But this baby was admitted to the ward, doctor, not in nursery, not in intensive care. Intensive care, we don't discharge them Lama, definitely. Thank you.
Okay, Khalid Danish, بس اختصر الله يخليك.
يعني I was in the medical legal committee in Jeddah for 6 years, and we used format from the governor, the princess of the Jeddah or the Mecca, that before we investigate, the accuser should read and sign a paper that if his vague complaint, the doctors has a right and the hospital concerned has the right to sue them or to sue here the family in the court. 80% they don't come back. We give him 1 week to read and sign. And that's what an official letter من أمير المنطقة في مكة.
هذا smart way, excellent.
يعني if we have this, we could save time.
Excellent.
For the medical legal. I've been accused 2 times and it was a fake. يعني حماية ما قدرت أحمي نفسي.
Excellent. طيب بروفيسور سعد.
دكتور خالد بس تعليق على كلامك، احنا قررنا انه كل واحد يقدم شكوى يدفع مبلغ معين. اذا جاته القضيه ياخذ المبلغ والديه اللي معاها. لكن الامر ما موافق عليه الان، لازم من فوق يقول لك.
So it's just a suggestion, yeah.
My question is
مو نوقع يدفع مبلغ معين قبل ما يقدم اي شكوى على دكتور. المبلغ هذا يحفظ عندنا او يحفظ في الماليه. اذا جاته القضيه وكسب القضيه مع الديه ترجع له، لكن ما وافق عليه الان.
نعم. طيب سعد تفضل.
What about the newspapers when they, talk about these things in excitement way from one aspect? Is it possible for me as a physician, if it's termed to be not the right to sue the newspaper?
Newspaper and Twitter. Now everybody complaining in the Twitter, really. And there is our colleagues, they write their name clearly, Dr. So-and-so, he had this and this. So I think also, no, but Twitter, like it's huge.
No question about the newspaper right now.
But even in Twitter, they can bring them back if there is a law about it. تفضل دكتور عبد الحميد.
Newspaper, you can complain للأمارة، تحط صورة الخطأ أو المقال، تقدم شكوى عليهم، بس عن طريق الأمارة، مو عن طريق اللجنة.
نعم. We can end by 2 quick questions, but short, please, Dr. Ali.
Thank you much, Dr. Katan. I have another perspective, actually, for the point of journalists. I wonder if home care, I mean, visiting these babies at home and doing the necessary investigations by dedicated nurses and residents, I think this is almost most of the problem, because one at a time visit in the clinic is not enough, because jaundice is a dynamic process. So it's not enough to see them once. I mean, home care is the best solution in this country, I think so.
Excellent. You are يعني affected by the British way of doing things.
This is
any comment, Dubara, about it?
Actually, some hospitals, they have home health care, but only for sick and,
terminal patients.
For terminal patient, but they don't do it in pediatric, like anyone with pediatric. So how we need really a lot of resources, a lot of personnel, a big program to encounter for the home health care or home visit like UK or Canada.
Yes, but this is the only one. It's not only jaundice. It's
Yeah.
many things that babies are not well, cardiac. This can be.
Yeah,
This is-
breastfeeding and
yes,
jaundice,
that's
and
right.
this is what happened. But I think, inshallah, in the future, but it really need a lot of resources.
شكرا شكرا جبارة.
Can I make home care comment?
I will give you time. Just a second. اتفضل يا دكتور. Short, quick.
Okay, thank you. It's not a question for Dr. Jubara. It's only interesting to know what happened to the interesting case you present, methyl hemoglobinemia, this type 2, picked up early and they started treatment early. Just any follow-up for this case, or or has any problem?
Yeah, we see her in the clinic. Unfortunately, she started to have some delayed. So this is at age almost 5 months. And, to all cases of type 2, it's not carrying a good prognosis, even if you start treatment early. Because when we look to her cord hemoglobin, it was 30. So I think she had sustained, injury with neurological impairment earlier. And all the cases which report with type 2, it's a lethal. So nothing has been reported as a baby who survived with type 2 methemoglobinemia.
Thank you. Now we have 2 quick comments from the podium here. Dr. Abbas first.
We have the experience of having home vaccination in my hospital, and we have difficulties. Sometimes if the father is not at home, they will not allow the team to go in. Okay.
I see.
And sometimes they wait 1 hour. So it's so many problems, but it's going. Home vaccination is going. Maybe we can.
You charge them, ya Abbas? You charge them?
Insurance companies, yeah.
But okay, if you charge them, fine. It's okay. Then that's good. Last comment from my colleague, Dr. Abdurrahman Matari. تفضل.
Yeah, I just want to saying about blood transfusion complication and mentioned by Dr. Tariq Awda. First of all, very interesting. I mean, I have written and in the process, inshallah, for publication, 2 papers about blood transfusion. And one of them, I come up with the conclusion that in Islam, blood transfusion is not permissive. يعني مطلقا. What we know, just for every baby, we are giving blood. As Dr. Tariq mentioned, there is risk. It may be minor, but it is there. So, and many times we transfuse the babies for no good reason. So I have good data for a lot of babies have been transfused and they have significant morbidities comparing to those group who's not transfused.
طيب يا عبد الرحمن. إذا نسمع كومنت من طارق.
Thank you. I totally agree. I think the first rule in transfusion medicine, not to transfuse. So if you can do anything without transfusion, that's the first rule. But definitely in as we see in the hyperbilirubinemia, you need to have some areas where you need to use the blood. Minimize that by all the measures that you need to take, the safety of the blood that is being taken care by the blood banks, and the safety that should be taken care by the ordering physician, ordering the compatibility. Be sure that the recipient of the blood is in a good shape and in a need for that. And adding to that, a follow-up. And unfortunately, many of the transfusion, the patient receive a transfusion and left over. No one follow up. And in the future, when he or she needs a transfusion, they discover that there was a miss in his previous transfusion, and now he has incompatibility issue or a complication associated with the transfusion.
Thank you. At the end, I would like to thank all the podium, all of the audience. Thank you for waiting with us till the end of this session. And I would like to ask you to come back after the prayer and lunch. We'll start at 1:15. We will have our last session, which will be, you will see again Abbas Al-Amran. He will be there in this session. And we will have the research papers, and the competition will be to choose 3 winning research afternoon, inshallah. We will try to conclude the whole meeting by 2:30, inshallah. So come back and enjoy your lunch. Okay, you want to do this? Thank you.
Check one. Sound check. Test one. Sound. Test one. Check. Testing. Hey. Sound check. 1, 2.
Check, sir. Okay.
أنا فاضي للساعة. طيب, for the sake of time, let me welcome you back again for the last session, session number 10. It's actually a research session assessment. وبعدين we'll see 5 presentation. The winner 1, 2, and 3, 5, 3, and 2,000 riyals. But before we start the session, let me introduce the chairman, Professor Khalid Al-Faleh, senior consultant neonatologist. كان معانا بالشرد, one of the staff of King Saud University Medical City, and now he is with Al Habib Group as a senior professor of neonatology. Second co-chairman, Professor Saad Saadi, and everybody know him. He is the president of the Saudi Neonatology Society for quite long times. وأنا جيت بعده وأستاذ في جامعة الملك عبد العزيز. Before we start our research, we have leftover presentation by Dr. Abbas Ramran for neonatal jaundice. So he will take short times, and then we'll start our research session. تفضل يا دكتور عباس. You will tell us.
Bismillah ar-Rahman ar-Rahim. This is a deferred lecture, not deferred clumping of the umbilicus. Anyway, back to jaundice, but from a different angle. This is a very rare case that we encountered around 1 year ago. This baby was born at 36 weeks by spontaneous vaginal delivery, low birth weight with good Apgar scores, to a 28 primi gravida mom having hypothyroidism. She had ruptured hair membrane 31 hours prior to delivery, but she received adequate antibiotic prophylaxis, and she had a full course of dexamethasone, and her CBC, mother CBC, was normal. The baby's assessment initially was normal. He went to nursery to monitor her blood sugar, and her initial CBC was showing normal parameters, including the platelets of 441 thousandths per unit per liter. The blood group of both baby and mama were O positive, and suddenly at around 10 hours of age, the baby was jaundice, and the transcutaneous bilirubin was 185. The baby was admitted to the NICU right away, and the serum bilirubin actually came up to 220. So the baby was started on intensive phototherapy. Her physical examination was unremarkable apart from the deep jaundice. There were no PTKI. Because of the feeding was slow, according to the nurses, we started also antibiotics, taking the history into consideration. If you look in here, and this is the true photocopy of the bilirubin chart of the baby, the one on the left side, you can see the first bilirubin transcutaneous was high above the phototherapy level, as well as the serum bilirubin was increasing in the first 12 hours. But it is below the exchange level, as it is indicated on the other picture. The G6PD assay was normal, came the next day. The morphology of the RBC morphology was reported benign. It did not help us in the diagnosis, and the direct comp test was negative. But the CBC that we did with the serum bilirubin showed thrombocytopenia. The platelets were 21 only. And we consulted the hematologist, and he suggested to start IV immunoglobulin, keeping in mind alloimmune thrombocytopenia. We needed to insert UVC for this baby for IV access, and we gave the IV immunoglobulin at 50 hours. But the platelets further came down to 13,000. So the hematologist suggested to add steroids, but we gave platelets at 58 hours, and we needed to give also packed RBC transfusion because the hemoglobin dropped down to 8.5 grams. So there's jaundice and hemolysis and thrombocytopenia. This was the picture of the RBC morphology, and this was reported by our lab as non-specific changes. They did not give us any clue for the diagnosis. But fortunately, our hematologist was questioning their results. So he took the sample, he sent it to hematopathologist who diagnosed this as microangiopathic hemolytic anemia. As you see in here, there are many fragmented RBCs, hamlet cells, schizocytes, and very few platelets if seen. So making altogether a case of severe early neonatal indirect hyperbilirubinemia together with severe thrombocytopenia and hemolytic anemia. This could be microangiopathic hemolytic disease. And if it is very early congenital like this, our hematologist suggested that this is the case of congenital thrombotic thrombocytopenia, thrombocytopenic purpura. To make this diagnosis of congenital TTP, you have to do Adams 13 level in the serum. So we send this and we started treatment right away. The treatment is to give fresh frozen plasma. So the baby was transfused initially on 78 hours of age, given 2 more doses, and look at the results in here. As you see, this is the serum bilirubin. We started at 11 hours of serum bilirubin of 220, and with intensive phototherapy, it decreased gradually. But when we started FFP transfusion, the serum bilirubin never went up more than around 100 micromole. So the baby responded to the treatment. And this is the hemoglobin level. The hemoglobin was dropping steadily. We gave blood, it raised, and then never went down again after FFP transfusion. The platelet count, as it is shown in here, we started the baby's platelets with 411,000, dropped to 21 when the baby was admitted to the NICU. And then actually we questioned the reading, but we repeated soon. And as you see, it came to 13. We gave 1 dose of IV immunoglobulin for the possibility of alloimmune, but it didn't help actually. And the platelets, we gave platelets transfusion. And then when we made the diagnosis of, or we suspected congenital thrombotic thrombocytopenic purpura, we started the FFP transfusion, and the platelet went up gradually to 200 plus at day 6, and then at day 13 it was 900. This is to show, because these babies are prone to develop kidney and brain problems. We did renal function follow-up, and it was normal, together with direct hyperbilirubinemia. It was raised at one stage, but went back. There was some evidence of hemolysis. The retics went up to 7, and the LDH was high, but with the treatment, it came down. We investigated the baby fully. Her electrolytes were normal, serum albumin, liver function, G6PD was normal. PT and PTT were normal, blood culture was sterile, and the hemoglobin electrophoresis was normal. We did also cranial ultrasound looking for hemorrhage. We did it twice and it was normal. And later we got the results of the serum Adams 13, which if you want to open it, it's a long name, but I think just keep it in mind, Adams 13. Adam 13 activity was, as it is seen here in the underlined red line, the level was very low, 0.09 international unit per ml, and the normal at least should be 0.4. To differentiate it from acquired, where they have antibodies to Adams 13, we did also the antibodies, but it was normal. It was negative. So the baby was discharged on day 8 in good condition. The jaundice was minimum, and he was seen 3 times at the OBD in the first month, and he received FFP at day 13 and day 30. So I'll give you some information about the congenital, or it's called hereditary thrombotic thrombocytopenia. It's also known as Upshaw-Chalman syndrome, and it has the OMM number of 274,150. It's a very rare autosomal recessive disorder, and it's caused by the mutations that results in the absence or severe deficiency of Adams 13. Adams 13 is required to cleavage the von Willebrand factor multimers. And if you have decreased activity with an increased size of Willebrand disease, this increases the risk of microvascular thrombosis and anemia. The gene was mapped as at the long arm of chromosome 9. And the disease is usually characterized by episodes of microangiopathic hemolytic anemia, together with small vessel platelet thrombi and severe thrombocytopenia, and later on with organ damage, particularly the brain and kidneys. The initial disease manifests in the neonatal period usually, but could pass into adulthood without notice if the baby didn't have symptoms. And if not treated promptly, the mortality rate is very high. It was first reported in 1975 when 3 of 4 affected children in one family died. The exacerbation with pregnancy was recognized in 1976. Pregnant women could have exacerbation. And in 1977, it was recognized that FFP was an effective treatment. In 1998, the severe deficiency of plasma Adams 13 was recognized as an etiology, and in 2001, the mutation for Adams 13 were identified. And the first large series was reported in 2011. This is a very recent review article on all cases reported between 2001 and 2020, over 20 years. There were 220 cases from 96 reports. The age of diagnosis was reported in 220, 117 were females and 85 were males. The disease is more in females because it occurs more during pregnancy, apart from the neonatal period. But 83 patients of these had severe neonatal jaundice, and HTTP was suspected and effectively treated on only 3 patients. So this disease is unknown. Of the 217 patients who survived infancy, 1/3 of them had major morbidities that occurred at a median age of 21 years, including stroke or transient ischemic attacks, or kidney injury requiring dialysis, or what is now called renal replacement therapy, or cardiac injury, including myocardial infarction, congestive heart failure, or cardiomyopathy. So all major morbidities. 62 patients had stroke. 13 of them occurred during the first 10 years. So it's a disease of childhood. Of the 54 patients who survived their initial major morbidity and were subsequently observed, 37, 2/3 of them, had sustained a subsequent major morbidity. And those who lived 40 years or more, half of them had experienced major morbidities. The FFP prophylaxis was initiated in 44 patients on this series, and 1/3 of them had major morbidity reoccurred even after or on prophylaxis. So the pathogenesis, the disease is caused by severe deficiency of ADAMS 13, which could be either acquired or hereditary, and we are concerned here about the hereditary one due to mutations. And ADAMS 13 is required for the proteolysis of Van Willebrand factor following its secretion by the endothelium. In this picture, simply, this is the ADAMS 13 on the pointer, and these are the platelets, and this is ADAMS 13, and this is the von Willebrand factor. You see, it is coiling, and the platelets are away, but and then it cleaved. This von Willebrand factor is cleaved by the ADAMS 13, and then they recoil again and goes into the small vessels and distributed. But if you look in this picture, we don't have the ADAMS 13, the red triangles here. So the von Willebrand factor, they are very long. They call it extra large von Willebrand factors. And when they go into a small vessels, they form a clot. And because of the rapid and high speed blood flow, the RBCs are destroyed. So that's the name comes microangiopathic hemolytic anemia. So far, there are more than 200 mutations reported, and the prevalence of HTTP is 1 patient per 1 million people. The common mutation in North America and Europe is PR1060W. But according to a Norwegian study, this mutation is reported much more than the cases. So many cases probably are missed. This is the picture shown in here, showing the microangiopathic picture. And you need to screen the family for this disease if you have an index case. The clinical course is unpredictable, and clinical discrepancy between siblings of the same, carrying the same mutation are different, and children may be asymptomatic for years. The cause of exacerbation also is not known, but babies, they can present at birth, or they can be asymptomatic. And also there is another period of time when pregnant women also, they are at risk of developing manifestation. In Japan, hemolytic neonatal jaundice was documented in all 43 patients with the disease. 18 infants underwent exchange transfusion, and in Norway, 20 patients had the disease, and 9 of them underwent exchange transfusion, but none of these patients were diagnosed as HTTP at the time of exchange blood transfusion. So I think we are lucky we diagnosed the baby early. The acute neonatal episodes could be fatal.
Dr. Abbas, 2 minutes, please.
Sure, inshallah. Newborn who had presented with severe hyperbilirubinemia and anemia and severe thrombocytopenia died at 34 hours without exchange and without FFP, and later was diagnosed. So this case and similar cases make you have to have high index of suspicions to treat this baby simply with FFP. The neonatal period is high risk for developing the manifestation. For some reason, I don't have time to mention it. The management usually is FFP, and it's given 10 to 15 milligram over several days, and then baby should be put on prophylaxis like every 2 weeks. Once you start the prophylaxis, it should continue forever. But currently, the FFP prophylaxis is not considered for asymptomatic patients, even when they have mild thrombocytopenia. But this can carry the risk of developing problems later on, like cognitive impairment. Now, the future management, the potential efficiency of recombinant ADAMS 13 has been documented in initial clinical trials. And recombinant ADAMS 13 has the potential to revolutionize the management simply because simple self-parent administration, and it's given as 5 ml every 2 to 3 weeks. So in conclusion, HTTP is a rare disorder caused by severe ADAMS13 deficiency. It is commonly misdiagnosed or lately diagnosed. Major morbidities and death are at young age, common at young age. Replacement of ADAMS13 can prevent morbidities and mortalities. FFP prophylaxis currently is the treatment and the prophylaxis, but it's insufficient because still patients are developing morbidities. Use of recombinant ADAMS13 will be simple and safer and more effective. Take-home message: when you have severe neonatal jaundice associated with severe thrombocytopenia and microangiopathic hemolytic anemia, think of HTTP, and simple FFP is life-saving management. That's it. Assalamu alaikum.
Thank you so much, Dr. Abbas. We will open the floor for 2 questions only in order to proceed to the abstract presentations. Everyone was satisfied with the presentation, I guess. Has anyone seen a case like this before? We're younger than you, I don't think. Thank you so much, Dr. Abbas. We will proceed with the last session of this meeting. Start. Thank you so much.
We'll start our research session, and it's my pleasure to introduce Dr. Saad Al-Marri, who is a second-year fellow, a neonatal fellow in King Abdulaziz University Hospital. He's going to talk about the effect of booking status on the outcome of infant between 28 to 32 weeks gestation admitted to the NICU.
If you allow me, Dr. Saad, Prof. Saad, we'll just mention some housekeeping messages with regard to this abstract presentation session. There will be few abstracts to be presented. We will allow the presenter to have 10 minutes of presentation, and we will allow 1 or 2 brief questions in order to proceed to the next presentation. The Saudi Neonatology Society is hosting this award. It is an annual award. There will be 3 prizes presented to 3 best presentations. The first one will be awarded 5,000 riyal. The second one will be 3,000 riyal. And the third one will be 2,000 riyal. So we will proceed, and we will announce the results at the end of these presentations. Welcome, Dr. Saad.
Yes, sir. Assalamu alaikum. I'm Dr. Saad Al-Marri, an NICU fellow from King Abdulaziz University Hospital. First of all, I want to thank the organizing committee to let me chance to present my study. During our practice, we saw many cases of preterm, same age and same gestational age and weight, but has a different course. From when you go retrospectively, we saw one of the reasons is antenatal care. From this point, I chose this topic about effect of book status on outcome of infant more than or equal 32 weeks, gestational age admit to a neonatal intensive care unit in a tertiary academic center. This is my objectives, as shown the table. In an introduction, antenatal care should be include risk identification and screening, prevention and management of pregnant-related or concurrent disease, healthy education. And WHO recommend the antenatal care should be initiated with the first trimester of gestational age with at least 4 and optimally 8 visits during the pregnancy. In this study, was published at 2018, show the unbooked cases had lower education status, and unbooked mother had lower birth weight babies than booked mothers. And the other study published at 2020, systemic review and meta-analysis showed the overall bold estimated indicated the odds of neonatal death among neonate from women with antenatal care were 65%, lower than those neonate from women who had no antenatal care follow-up. Recently, the study published at 2021 showed the complete adherence to guideline during first visit reduced the risk of neonatal complications. Aim of this study, aim to study outcome of infant at more than or equal 32 weeks gestational admit to NICU at King Abdulaziz University Hospital, to booked comparing to those of unbooked mothers. The materials and the methods. Study design was a retrospective chart review from January 1st, 2021 to December 31st, 2021. Settings. The NICU there has a level 2 and level 3 with an NICU bed with the average number 2,800 deliveries per year with admission rate approximately 12.9%. Maternal and infant characteristics were retrieved from electronic medical record and prepared chart by trained data collector. Population. The inclusion criteria for the study, infant born at more than or equal 32 weeks gestation and admit to NICU at King Abdulaziz during the study period. Exclusion, outborn infant. About define of booked mother and unbooked mother. Booked mother, in our hospital, the policy, booked mother, those attend at least 3 antenatal care visit, and unbooked who less than 3 or not attend at all. Sample size, all consecutive infant who met the inclusion criteria during the study period were included. Statistical analysis, the data was performed using SPSS version 2022, and the categorical variables, they use chi-square test and continuous variable for independent students t-test for normal distribution. And Manutini U-test for do not follow the normal distribution. Logistic regression was cured and adjust odds ratio and 95% of confidence interval of neonatal mortality. Study outcomes. The primary outcomes of study to see the length of stay, and the secondary outcomes at shown in other column about birth weight, gestational age, need of resuscitation, congenital anomaly, RDS, sepsis, hypoglycemia, seizure, and mortality. Ethical approval. The study was approved by the Unit of Biomedical Ethical in King Abdulaziz University Hospital. Result. 186 infants were included. Approximately 30%, 57 infants were born to unbooked mothers. This, when you see here the first table about baseline demographic and prenatal characteristic, the first column about unbooked and booked, when you see the significant result here in nationality and the age of the mother, and most of mode of delivery of this infants was CS, and most of this was emergency, and comorbidities of mother was mostly diabetes and hypothyroidism. The other table showed the postnatal and delivery outcomes. When you see here, there is significant result about needs of resuscitation in unbooked mother and also jaundice and hypoglycemia. But the primary outcomes was not significant about length of stay, was median about 10 days. Another table about maternal and fetal predictors of neonatal mortality. When you see here, the maternal booked was have insignificant confidence interval. And also, as mentioned before, length of stay was insignificant for both groups. Strengths and limitations. In strengths, the consecutive inclusion for all eligible infants to avoid selection bias and single data collector. And the limitations for this study was a retrospective study and the sample size of study and lack of power to detect smaller clinical significant difference. In conclusion, the study relieved suboptimal adherence to antenatal care practice among pregnant women whose children were admitted to NICU. Also indicated poorer maternal and fetal outcome in unbooked women include emergency CS, neonatal jaundice, hypoglycemia, and the need for resuscitation. So the recommendation, non-national and unbooked mother should be embraced by healthcare system to accommodate them and afford appropriate antenatal and prenatal care for better outcomes. At the end, I want to thank scientific committee, my supervisor, and NICU team.
Any questions for Dr. Saad?
Yeah,
Yes, please.
Thanks, Dr. Saad. I have two short questions. The first is, you said those babies who are more than 32 weeks. So what is the upper gestational age limit? You didn't include full term, definitely. And why do you think these babies, they have more jaundice than the booked ones?
Thank you for this question. Yes, as we know, more than 32 week, usually baby, if has good antenatal care, usually become good outcomes. And more than 32 weeks usually don't stay long time in NICU.
Prof. Saleh.
Yeah, your primary outcome is the length of stay, right?
Yes.
And you found no difference?
No difference, yes.
So do you consider your study as a negative study?
We have the limitations in this study about sample size was affecting the power of study and can be as a negative study, yes.
Okay. We start with the next speaker.
Thank you so much, Dr. Saad. Our next presentation will be presented by Dr. Wiam Al-Saidawi, Assistant Consultant Neonatologist at King Faisal Hospital. She completed her Saudi Fellowship program at King Faisal Specialist Hospital. She's an American NRB instructor, mentor, and she's an adjunct assistant professor at Al Faisal University. Her presentation is titled Neonatal Hypoglycemia after Antenatal Corticosteroids in Late Preterm Infants. Welcome, Dr. Wiam.
Assalamu alaikum wa rahmatullahi wa barakatuh. Special thanks for the organizing committee to give me the opportunity to present my abstract or my research about neonatal hypoglycemia after antenatal corticosteroid in late preterm infant. The hypoglycemia is the most common metabolic disturbance occurring in the neonatal period. The use of antenatal corticosteroid after 34 weeks of gestation has been controversial in the past because inconsistent data about its efficacy and very limited data on long-term safety. It is now clear that infants who are born during the late preterm period have a more neonatal complication than term infants. The ELPS trial found that administration of antenatal betamethasone to women at risk of late preterm delivery decreased the need of substantial neonatal respiratory support during the first 72 hours. Additionally, studies found that significant increase in the rate of neonatal hypoglycemia in infants exposed to antenatal steroids. The aim of the study was to determine the frequency of hypoglycemia at 24 and 72 hours after birth in late preterm infants who were exposed to antenatal steroids. Also to determine the prematurity complication in late preterm infants who were exposed to antenatal steroids. Primary outcome, the frequency of hypoglycemia in late preterm at 24 hours and 72 hours post-delivery. The secondary outcome, the development of RDS, the need of surfactant administration, and the rate of the following: NEC, IVH, PVL, ROP, and bronchopulmonary dysplasia, and neonatal sepsis. Our source of data, it was electronic in ICU database, integrated chart information system, ISIS, and patient charts. The study design, it was a retrospective cohort study, including all late preterm infants between 34 weeks and 36 plus 6 weeks of gestation who were delivered in our institution between January 2016 and December 2020. The ethical approver, Research Ethics Committee, approved the study with RAC number of 2211098. Statistical analysis for the continuous variable t-test was used in the distribution was normal, and Mann-Whitney test if the distribution was skewed. Fish exact test and chi-square tests were used in categorical variables, and statistical significance was confirmed at p-value less than 0.05. Our institution began to offer the antenatal corticosteroid to patients in late preterm period in February 2016, either on the dosage 24 milligram dexamethasone, 4 doses at 6 milligram Q12 hours apart, or 24 milligram of betamethasone, 2 doses of 12 milligram in 24 hours apart. All preterm included in the study 34-weeker to 36 plus 6, delivered in our institution between January 2016 and December 2020. 2 mothers who received antenatal steroid were included in our study. The infant excluded from the study part of multiple gestation, pre-gestational and gestational diabetes, chorioammonitis, and major congenital anomalies. The method, it was the methodology. Maternal data included the age and gravity, parity, and number of abortion, complication of pregnancy, antenatal steroids, the mode of delivery, and maternal infection. Neonatal data included demographic data, hypoglycemia event at 24 and 72 hours, complication of prematurity, RDS, surfactant, and surfactant administration, NEC, IVH, PVL, sepsis, and bronchopulmonary dysplasia, ROP. Neonatal hypoglycemia was defined as glucose less than 45 milligram per deciliter, 2.6 millimole within the 72 hours at birth. The result, during the 5 years study, the period, total of 192 late preterm infants were included in the study. Of this infant, 66 were exposed in the antenatal steroids group 1, and 126 cases were exposed in antenatal steroids group 2. Maternal demographic data were similar between the two groups, and we can see here in the table maternal age and gravida, para, and abortion. No significant p-value with maternal antibiotic and maternal infection. It was not significant between the two groups. There was no statistical significance difference between the two groups at birth weight and Apgar score, and the gestational age in group 2 was higher than group 1 with a p-value 0.002. We can see it here in the table. All the same, no significant difference between them. Only the gestational age was higher in the no antenatal steroids group. Neonatal hypoglycemia in the first 24 hours was higher, statistically significant in steroid group 55 versus 30% with a p-value 0.01, while 72 hours hypoglycemia events were statistically not significant between the two groups, with 7.69 versus 5.5 with a p-value 0.544. This is, we can see it in table 3, where the event in the first 24 hours was significant. At 72 hours, it was not significant. However, the rate of RDS was statistically lower in group 1, 23 versus 44 with a p-value 0.004. Additionally, surfactant was used more in group 2 with 1.54 versus 11 with a p-value 0.013. The other complication of prematurity, IVH, ROP, PDA, and bronchopulmonary dysplasia, neonatal sepsis, and neonatal death were similar between the two groups. This is the table 4 can show the RDS and surfactant. It was significant less in the antenatal steroids group. In this study, we found that late preterm infants who were exposed to antenatal steroid had decreased the rate of RDS and the need of surfactant use. We also found there was no significant increase in the rate of hypoglycemia in the first 24 hours at age, but did not differ between 24 and 72 hours of age. We found that antenatal steroid did not significantly affect the rate of neonatal sepsis and the complication of prematurity. In comparison to the ELPS trial, our study echoed similar result in terms of statistical significant increase in neonatal hypoglycemia and the reduction in surfactant use in steroid group. Also similar to ELPS trial, our study showed similar result regarding the rate of peripartum maternal and neonatal infection, where there were no statistical significant difference between the two groups. The strength of our study, the strength of the study, excellent control, and well-grounded positive finding that can be generalized and considered in the clinical practice. To the best of our knowledge, this is the first study, I think, done in Saudi Arabia. The limitation of the study, it was retrospective cohort study with limited number of patients. A well-designed multi-center prospective trial with adequate sample size is recommended. The conclusion, we concluded that administration of antenatal corticosteroid to pregnant women at risk of late preterm delivery significantly increased the risk of hypoglycemia in the first 24 hours. However, the hypoglycemia event in the 72 hours was resolved. Also, there was decrease in the rate of RDS and the need of surfactant therapy. This is my references, and thank you for listening.
Thank you so much, Dr. Wiam. Any questions regarding this presentation? Dr. Sajjad.
Yeah, thank you very much. It was an excellent study. So what is the mechanism of this hypoglycemia, which results secondary to antenatal steroids?
The mechanism not well known. There is two mechanisms, or from the antenatal late steroids, the antenatal steroid for the mother can cause hyperglycemia. This can cause hyperinsulinism for the baby, so inducing hypoglycemia in the first 24 hours, and it is transient and resolved. Also, there is another theory, maybe adrenal suppression from the steroids.
Thank you.
Thank you, Dr. Wiam. Do you think your study can have some implication to our current practice?
Yes, it will help, yeah.
In what way?
In reducing the RDS, the length of stay, the use of surfactant therapy, mechanical ventilation.
Would you do anything to prevent hypoglycemia in those infants?
Monitoring them as at risk. If we know this mother, she is taking antenatal steroid late preterm, we'll monitor them for hypoglycemia. If they need admission, we'll admit them for that.
Thank you so much for your excellent presentation.
Thank you, Doctor.
We'll move on to the third presentation of the day. Dr.
The third presentation will be by Ms. Fita Peter. She's going to talk about implementation of early CPAP initiation in the delivery room for preterm neonate, gestational age between 28 to 32, decreased the mortality rate by reducing the need for intubation. Ms. Fita is a hospital management neonatal nurse specialist in RB instructor and also stable instructor, King Saud Medical City. Thank you.
Good afternoon. Thank you, Dr. Said, for the introduction. And first of all, I would like to thank the scientific committee for giving the opportunity to share the experience. I'm going to present a quality improvement project which was done in our NICU King Saud Medical City during the pandemic from April 2021 till March 2022 for 12 months. The project title, Implementation of Early CPAP Initiation in the Delivery Room. Babies who are born between 28 to 32 weeks of gestation and decrease the mortality rate by reducing the need for intubation. To begin, as we all know, RDS is one of the most frequent causes of respiratory failure and death among preterm infants. And the standard treatments were invasive mechanical ventilation and surfactant administration. Current evidence-based studies demonstrated the initiation of CPAP significantly reduced the need of intubation, mechanical ventilation, and exogenous surfactant. So what is the reason for starting this project? So in our NICU, CPAP was not previously initiated, especially for the preterm babies less than 32 weeks, due to many challenges. The main reason for starting this project, we had, I was brought to attention to review the CPG protocols for CPAP. So that time we dig to the data from April 2020, March 2021. The babies who are born between 28 to 32 weeks of gestation, 0% of babies initiated CPAP in the delivery room. And out of that, 97 babies intubated and transferred to NICU. And 3 babies started on nasal cannula. Once they reached the NICU, they were initiated CPAP in the NICU. So we sit together to identify the problems. We did brainstorming. The first and foremost, the problem was if any baby delivered to less than 32 weeks, immediately intubation was done. The main thing is the first major challenge was the supply issue. We don't have equipment, new puff or TP's resuscitator in the delivery room. And also the consumables related to that. The second thing, because there was no supplies there, so the staffs lack knowledge regarding the CPAP initiation in the delivery room. And also there was no clear criteria when to initiate the CPAP in the delivery room. And as the universal problem was the staffing, especially we send only one physician and one nurse to attend the high-risk deliveries because of lack of shortages, lack of shortage of RT and also the nurses. And there were no documentation to monitor the vital signs, to monitor the compliance in the delivery room. Once they resuscitated, they will bring the patient to NICU. After that, they will start doing the documentation in their nurses' notes. Nurses and physicians are the same. So with all these challenges, we plan to start this project. Our objective was to increase the use of CPAP as a primary mode of respiratory support in the delivery room, to reduce the need for intubation. So we selected the first thing, we selected our criteria. We selected the age group between 28 to 32 weeks. The baseline also was 28 to 32 weeks. We found 165 babies. So the first criteria was a good respiratory effort, heart rate more than 100, no known contraindications for CPAP. So this is the reference from the NRP, as we all know. And we initiated because we had a very big challenges. So we have taken actions before our implementation. The first thing, we had a clear criteria and we put our CPG guidelines, and webinar was conducted by our physician to all the physicians. And also we formulated the form to monitor the vital signs in the delivery room while doing the resuscitation. And we provided the radiant warmer, which was built-in TPs resuscitated to all the delivery rooms, including the labor room and OR. And after that, we tried to get a CPAP supply. It was very hard, and by the hospital administration, they have tried to get it through the direct purchase. Then we started providing at the same time NICU staff training for the nurses, for the physicians, and also doctors how to use the TPs resuscitator in the delivery room. So with all these challenges, we moved, we start a CPAP initiation campaign, and we started the project on 1st April 2021. And the major challenge was actually once we start implementing the project, we started doing the team with one physician, one nurse, and one RT to attend all the high-risk deliveries with all the shortages, and a time frame for 12 months, as I mentioned to you. So the implementation phase, during the implementation, so after we started within the first 3 months, we went through many restraining forces. The first and foremost, some physicians were really hesitant to initiate CPAP. The major challenge was the transportation issue, because they have to, our transportation issue means a hospital from the delivery room to the NICU. To transfer a patient, it will take almost 15 to 20 minutes because it's a different hospital. So this was one of the issues. So they were comfortable to intubate the baby and transfer the baby to NICU, then to extubate after 5 hours or 6 hours. This was our practice. So some physicians were still hesitant and reluctant to initiate CPAP. So what we did, we tried to monitor, we informed the nursing staff to monitor, to put the criteria in the delivery room. And if any baby is born, if they will do the initial assessment. If the baby fit with the criteria, the nurse will show it to the physician that this patient is for CPAP initiation. So that's how we start motivating the physicians to initiate the CPAP in the delivery room. Sometimes they were very reluctant. So this every day on daily basis, we used to monitor the CPR form. And if the patient fit the criteria and still they intubated the patient, the doctors were assigned to follow up to do an individual counseling with the physicians. And the next major challenge during the implementation phase was the limited medical supplies. That was also solved through that hospital administration. And as we always talk about the staff shortage, one day the nurses, all of them, they came to my office and they said, we were not going to continue the project because it is very hard to convince the physician. The second thing, shortage, we cannot do the documentation, we cannot monitor the patient because only one nurse is she has to assist with the physician. So we sit and we try to talk to the nurses, convince the nurses, explaining about the outcome of this project. And then we try to assign 2 nurses, one to document and one to assist. And at the same time, we assign the RTs also to participate in this, attend the delivery during the, especially for this high-risk deliveries. So by then we try to solve the issue. We try to convince the physician, convince the nurses to move on this project. And also they were resistant to document because before there was no documentation. So later with all this explanation and meetings, and they were complying with all the instructions. So with this, we found almost, because it was a COVID time, and our hospital is one of the referral hospital. So we had high number of referral cases at that time. So as you can see in the baseline, it was only 165 patients. And during our project for 12 months, total number of preterm babies admitted between 28 to 32 weeks, it's almost 227 babies. So with all this challenge, out of this 227 babies, 108 babies were initiated CPAP because they met the criteria, and 119 were intubated and transferred to NIC because they did not meet the criteria. And some of the babies were even though they met the criteria, but still in the initial phase they were intubated. So what was the outcome? The major objective was to increase the CPAP rate and to decrease the intubation rate. So as you can see in the graph, this is for the babies who are initiated CPAP, almost 108 babies. As you can see, from 0%, it increased to 69 in the first quarter. Then we tried to maintain the 100% compliance. And as you can see, the intubation rate, it reduced to 31 and 0. After that, it was now continuing this. So this graph shows for the overall babies. So the first graph, it was only babies who are initiated CPAP. This baby is initiated CPAP plus intubated. So total 27 babies. You can see the intubation rate is declining, and CPAP rate was increasing to 67, 91, 83.
Ms. Rita, 1 minute to go.
Sure. So 65%. So these are the major outcomes. This was our primary outcomes. And after that, we compare with the mortality rate. We found the mortality rate reduced for the CPAP babies from 17 to 0%. And overall, the mortality rate reduced from 17 to 7%. Then we tried to measure the secondary outcomes, ROP, CLD, and IVH grade 3 and 4. And out of the CPAP babies, we found there was 0% of severe ROP, CLD, IVH, and also the NEC. And this is overall outcome for the overall babies, around 227 babies. ROP rate was decreased and IVH is quietly decreased. CLD not significantly reduced, but NEC rate was reduced because I cannot say NEC rate is because of this project, because we had another project for exclusive EBM, so that can really reduce the NEC rate. So just we were the winner for this project, International Hospital Federation for Patient Safety and Quality. And this was awarded in this month, 10th November in Dubai. So I would like to conclude the major role was played by the nurses. So mainly we talk about the universal, why do nurses resist changes? So always, if you want the project to be done and if you want to maintain a continuous quality improvement in the patient care, we need the full cooperation from the nurses. So nursing shortage is always, if you ask anyone, they will say 99.9%, they will say, talk about nursing shortage, it is universal. So that is not the end. Nurse leaders play a very significant role in continuous quality improvement in patient care. So that we need to think about. I would like to conclude and thank my
you
team.
very much. Thank you. Any questions, please?
There is one question. If you can
Okay,
allow me.
please.
Thank you very much. I think it was a very good presentation by the nursing colleagues. My question is, what exact CPAP machine and CPAP interface were you using? And secondly, how were you excluding choanal atresia before starting CPAP?
Sorry, the first question, sorry. Okay, sorry, we were using the Tradiant warmer, which was built in the TP's resuscitator. So it is a resuscitator, which you can see built-in TP's resuscitator. Yeah, nasal with using the prongs or mask, yes. Mask, nasal.
What was the second question? Sajjad?
Yeah, second was, how were you excluding choanal atresia before starting CPAP? She said one of the exclusion criteria was choanal atresia. So how did she actually exclude
How did
that?
you exclude
Yeah.
choanal atresia in your population?
Yeah, sure. The thing is, actually, this was our criteria, but during our implementation process, we did not come across the case. As we all know, this choanal atresia, you cannot start the nasal prongs. Sometimes we have supplies with the prongs or mask. So that is the main reason we put exclusion criteria for the CPAP.
Thank you.
Thank you.
Doctor, تفضل.
Thank you for this presentation. I just ask, any of this group received LISA before you start CPAP, or all no Cervanta given at all? Yeah.
What we did when
They give less invasive surfactant administration, or all CPAP from the start without giving any Cervanta?
Without giving surfactant.
All CPAP?
Yes. Some babies need intubation after that, so we intubated and given surfactant.
Yes, thank you.
Thank you so much. Another question? Thank you so much, Vita. Thank you. We'll move on to the fourth presentation of our abstract presentation session. This next presentation will be presented by Muhammad Bahadur, medical student in the National Guard Hospital of Jeddah. And he will be presenting today on survival and predictors of mortality of congenital diaphragmatic hernia in tertiary care center in Saudi Arabia. Welcome, Dr. Muhammad.
This one. This one? Now I did it. Can I use the mouse here? Yes, okay.
Assalamu alaikum, everyone. Good evening. I am Mohammed Bahadur, a 6-year medical student at King Saud bin Abdulaziz University at Jeddah. I'm very happy to be here today, and I would like to thank the conference organizing and scientific committee for inviting me and to present and giving me this opportunity. I believe this research will help in the practice and will also benefit our little precious newborns. So this research under the title of Survival and Predictors of Mortality of Congenital Diaphragmatic Hernia in Newborns at a tertiary care hospital in Jeddah, King Abdulaziz Medical City, National Guard. This research was supervised by Dr. Mohammed Al-Hindi, and also I would like to thank Dr. Mansour Al-Qurashi, the Dean of our college, and Dr. Ahmed Mustafa, and of course, Dr. Jabara for their continuous support and teaching. This is the outline. Going to start with the background. Why is this study significant? Going to talk about the aim, methods, results, and discussion along with each other, and end up with a conclusion and recommendations. So, congenital diaphragmatic hernia is a rare conditional disease that approximately happen at a rate of 0.03 worldwide. This is a percent. We found a couple of studies. We have two studies whose estimated prevalence. This one is an international European surveillance for congenital diaphragmatic hernia. 31 studies with an estimation of 1 per 4,347 live birth. Also, we have here King Fahd Hospital in Al-Baha did a study, and you can see it's 1 per 2,320. This was happening 11 years from 1981 to 1982. We will talk about the difference of the rate later. As you can see, here's the mortality rate. Internationally and nationally, we have the kids and patient database from USA, 51%, and you can see that all the rates in the local are similar to one in the international. As you can see, the incidence was low or rare. However, the mortality is a great significance with such a disease. Thus, some studies did tools that can predict mortality. These are some of them. I'm not gonna mention them all. There are antenatal and postnatal. We have lung head ratio by ultrasound. This is an antenatal tool to predict mortality. For example, if it's more than 1, it's a better prognosis. We have the CDH study group, probability of survival. This is also a score that can be calculated with, for example, low birth weight, low Apgar, and etc. We have Bindle score and SNAP2, of course, we mostly familiar with. And we have the defect size. More on that later. So why is our study significant? Up to our knowledge, this is the first study to use or study the predictors of mortality here in Saudi Arabia. We calculated the prevalence and mortality to provide clinicians with the general estimate, not only the clinicians, but also for the parents. We want to establish a benchmark scores that can predict mortality and survival. Why? To help allocate resources. The aim is to estimate survival, evaluate predictors with a statistical analysis. So briefly, the methods is a retrospective cohort study, included all newborns without exclusion from 2000 to 2021. That's a sum of 21 years in the King Abdulaziz Medical City, Department of Pediatrics, Division of Neonatology. So we compared, let's see here, we compared the prevalence, demographics, and clinical characteristics of the neonate and the mother between infants who survived and died. And we use C statistic to evaluate those predictor scores. More on that later. We need to explain something about the C statistics when it comes. So inclusion criteria, all newborns, exclusion, no exclusion. By default, this is non-probability consecutive sampling technique. The data collected from physical files and electronic files. In our center, we use BISCARE. This is the data collection done by students, mother, infants. We have the prenatal, and we have the postnatal, as you can see, from first hour of life to the 24, because some scores need that. For example, SNAP2. Okay, general characteristics of the neonates. We ended up with 45 patients in the 21 years. 80% of them were inborn and 20% were outborn. Why is that important? Because we want to only estimate the prevalence or incidence in our center. So we excluded the outborn from here. But the other outcomes, mortality and the clinical outcomes, we included the outborn. Mean birth weight, as you can see, it's similar between those survived and died. Mean gestational age also. Among those who died, 19 of them died preoperatively, and 4 of them died postoperatively. So we estimated the prevalence. So among the 21 years, we had 66,844 total birth. MashaAllah, tabarakallah. So we estimated only the newborns, it's 1 per 1,856. And the mortality rate was similar to the others, 51.1. Now let's compare it to the literature. When you compare it to the international, as you can see, we're almost double the incidence here in Saudi Arabia. And you can see we are similar to the one done in Al-Baha, 1 per 2,000. We're almost the same. Why is that? We can discuss it after the presentation, but we think that maybe consanguinity is a problem. And later for the recommendation to estimate that. Okay, on mortality, we have a similar mortality to the other studies internationally and locally. Let's start with the maternal characteristics. So when you look at this table, we have death, alive, and we have the p-value to estimate if there is significance. So there is no significant difference between those who died and alive in the maternal characteristic, not the age, not the body mass index, not the presence of comorbidity, delivery mode, delivery complications. And we go with the gravidity, parity, abortion, all been estimated, and there is no significant difference at time of diagnosis. But we have a significant difference in the inborn and outborn. As you can see, we have 9 outborns, only 1 of them died, and 8 survived. However, when you see the inborn 36, we have 22 of them died. Why is that? After discussion with Dr. Muhammad al-Hindi, Dr. Muhammad al-Qurashi, we, as a theory, all those who transfer to us might be discovered only incidentally, mild cases, or only referred for us for repair. So maybe that's a cause, but further studies or further analysis need to be done. Now with the neonatal characteristic, we have general characteristic labs and clinical. No significant difference regarding the gender, gestational age, associated anomaly, echo, whether it's prenatally or postnatally, and ultrasound, ECMO, MRI. But however, when we come to the laboratory findings, such as PF ratio, Apgar score, this is a clinical one. When we have the low pH, urine output, they're all significant. But this is by default, we expected that to be worse, and in those who died, this is the column for newborns who died. It's gonna be worse, of course, with those who died. However, we benefited from these outcomes for later to estimate the tools or the score. Remember, we just mentioned them. For example, we have SNAP2. We use this score by picking the worst of the variable. For example, mean blood pressure, low temperature, and etc. Now let's go and see. How did we see if these scores are significant? We use something or a tool called C-statistics. This one we picked because it was used.
Dr. Muhammad, 1 minute to go.
Okay, this one is used in the previous studies. So I'll give you an example for it. For example, lung head ratio. Among those who died, it was 0.89. Among those who lived, it's 1.5. What's the meaning of C-statistics here? 0.84. It means that 48% chance of what? Survival if the score is 1.5 or above. We didn't find significant difference in stomach herniation, liver herniation. However, we found in SNAP2, CDH study group probability, and Brindle score. And you can compare it also with the other studies. We compared them, and we are fairly similar with them. Strength, this is the first study to use a predictor of mortality here in Saudi Arabia. We are one of the few studies that calculate prevalence and mortality. The sample size was low. However, we managed, alhamdulillah, to get a statistical significance for such outcomes. It's and due to the retrospective cohort, missing data was happening. For example, the liver herniation, a lot of them, and consanguinity also was missing in a lot of patients. Our prevalence is high. However, we showed similar mortality to literature. We established and validated benchmark score. This is the beginning. Score that can predict survival to help allocate resources. We recommend and suggest a national multicentric registry for CDH. Why? To have a more accurate estimate of the validated predictor tools for the future. An example for consanguinity, for example, and the other tools. This is my beloved college. Thank you. And these are the references. You can scan the reference and you can take the slides for further teaching or something. Thank you very much.
يعطيك العافية. شكرا جزيلا دكتور محمد، ما شاء الله على الحماس. انت تقدر تقنع اي احد في الديتا حقتك ما شاء الله.
تعليم دكتور منصور.
طيب I have a question. Why did you say ما شاء الله تبارك الله على عدد الولادات اللي عندكم؟
الولادات طبعا نعمة. فحتى لو كانت 3 حقول ما شاء الله تبارك الله. الحمد لله هذه نعمة، والله يعين اللي ولدوا ويصبرهم اللي ولدوا بسيديتش.
Any questions? We need
Yes, feel free.
Not just you, Dr. Sajjad. We'll wait for other one. Doctor, I'll give you the next one.
Thank you, Dr. Muhammad, for this nice presentation. I want to ask you about any study related to the time of surgery, early or late surgery, to the outcome of mortality for this patient.
Is it working? Can you the beginning of the questions? I'm sorry.
There is a relation between early and late surgery to outcome of mortality. Is it different from late and early surgery?
Okay. First of all, I'm a medical student, but I can answer with what I know. In the literature, this is what I know. When we studied and we thought about the discussion, mostly died preoperatively because of the nature of the disease, and most of them. And that's the only explanation I can have. But if any one of you expert about the knowledge, let's have a discussion about why would.
I don't think you looked into that, huh? دكتور.
نعم، عندي question لك يا دكتور. الoutcome, is there any antenatal intervention done for those patients? You are talking about 50 patients. Any antenatal done intervention?
Can you bring the slides back, please? So as an antenatal intervention, we didn't measure that, but we had, for example, ultrasound antenatally. Okay. Let's see here, maternal characteristics. So we only included antenatal care if there is follow-ups, and mostly, not mostly, follow-ups were 36. Let's see here. Echo done prenatally, but 18 of them missing. That's why we need a registry. Such a disease is not documented well in Saudi Arabia, especially it's a rare disease. A lot of studies done here in Saudi Arabia. This is maybe a starting point to be aware of this disease with such high mortality.
طيب يعطيك العافية دكتور محمد. Thank you so much. We'll move on to the next presentation. You will present.
The last, not least speaker, Dr. Wid Fatani, senior medical student, King Saud bin Abdul Aziz University for Medical Health Sciences. She's going to talk about the accuracy of umbilical cord total blood count in detecting neonatal thrombocytopenia. Go ahead.
So good evening, good afternoon, everyone. My name is Fani. I'm a senior medical student from King Saud bin Abdul Aziz in Jeddah. First, I'd like to thank the Saudi Neonatology Society for this opportunity. And I'll be presenting our study entitled The Accuracy of Umbilical Cord CBC in Detecting Early Neonatal Thrombocytopenia. So a bit of background first. So early neonatal thrombocytopenia, which as we know is a platelet count of less than 150 in the first 3 days of life, is one of the feared hematological disorders due to its complications, such as perinatal intracranial hemorrhage. Umbilical cord CBC is a routine screening tool used for detecting different hematological abnormalities, including NTCP, in some hospitals. A follow-up infant CBC is done to confirm the diagnosis, subjecting neonates to iatrogenic blood loss and possibly wasting resources. Previous studies were conducted to assess the value of the cord CBC in predicting sepsis, screening for hematological disorders, such as in preterm infants. However, up to our knowledge, no other studies were done to assess the accuracy and sensitivity and specificity of umbilical cord CBC, specifically in diagnosing neonatal thrombocytopenia in both preterm and term infants. So this study aims to determine the accuracy of umbilical cord CBC to diagnose thrombocytopenia. Specific objectives were to measure sensitivities and specificity, as well as to measure the prevalence of neonatal thrombocytopenia in King Abdulaziz Medical City in Jeddah. So we used a cross-sectional study design with a matched control group. The study was conducted in the obstetrics and neonatology department in KMC. The study period was between May 2016 and May 2019. Our inclusion criteria was all live births in KMC between May 2016 and May 2019, with a routine umbilical cord CBC taken and intact. We selected controls of healthy newborns with intact cord and infant CBC randomly in a 1:2 ratio, matched for year of birth, gender, and gestational age. We excluded, however, neonates with major congenital anomalies and chromosomal abnormalities, neonates with antenatal diagnosis of immune and non-immune hydrocephalus. So we compared the cord platelet count to the gold standard infant CBC within 72 hours. We measured the prevalence, calculated the sensitivity, specificity, negative predictive value, and positive predictive value as per their definitions. So we found that out of 10,936 births in the study period, we identified 111 neonates with thrombocytopenia. We excluded those who did not meet our inclusion criteria, and we ended up with 40 thrombocytopenic neonates with intact cord CBC. We matched them to 80 healthy neonates, also with intact cord and infant blood samples. Our estimated prevalence was 10 per 1,000 live births, or 1.015%. We compared the characteristics of both the control group and the cases group. So we found statistical significant difference in the antenatal care, which was less in groups with thrombocytopenia. Also, there were higher rates of intrauterine growth restrictions and oligohydramnios. For the neonatal characteristic, we found that neonates with thrombocytopenia had more rates of neonatal sepsis, admissions to an ICU, platelet transfusions, as well as a higher mortality rate. For the lab parameters, apart from obviously platelet counts, there were no significant difference between the two groups. This is the classic 2x2 table we used to measure sensitivity and specificity. We used the confidence interval of 95% and estimated the sensitivity of 62.5%, specificity of 97.5%, a positive predictive value of 20.4%, and a negative predictive value of 99.61%. So what we found is the prevalence in our center was consistent with the local studies as well as international studies, which all estimated the prevalence between 1% and 5%. As expected, no antenatal care, intrauterine growth restriction, oligohydramnios are all risk factors affecting fetal well-being and making them more likely to have early neonatal thrombocytopenia. Also, neonates with NTCP were more likely to be admitted to an ICU, develop sepsis, receive platelet transfusions, and had higher mortality, as I mentioned, which highlights the importance of screening and early detection of neonatal thrombocytopenia. The high specificity and low sensitivity of this test aids physician to discharge patient with normal platelet count with high confidence without the need to repeat the CBC. However, a positive cord result cannot be fully relied on to diagnose the disease, and the follow-up is necessary for confirmation. Considering the low prevalence of neonatal thrombocytopenia, high negative predictive value means cord CBC can be safely used to reassure parents of babies with negative results, hence supporting our current practice of not repeating CBC of those healthy babies. However, the poor positive predictive value indicates the need for a thorough clinical history and examination and a follow-up CBC to confirm that diagnosis. The strength of our study are that we're one of the few to measure the local prevalence. Our study was adjusted for year of birth, gender, and gestational age, and up to our knowledge, it's the first to assess the accuracy. Limitations were due to the nature of the study. Missing data could not be controlled. The results only applies for early neonatal thrombocytopenia, and we had a relatively small sample size. In conclusion, neonatal thrombocytopenia is a rare but serious condition in Saudi Arabia. Thus, screening and early detection are recommended. Also, a high index of suspicion is essential for interpreting umbilical cord CBC platelet counts, especially when the results are positive. Thank you very much. These are my references.
Thank you very much, Dr. Awid, for this nice presentation. Now, it's open for a question. Prof. Saleh Aliyan.
Thank you very much. You mentioned that the positive predictive value is around 50 or something.
We can go back to it. Actually, the positive predictive value and the negative.
No, listen to my question.
Sorry. Yes, go ahead, Doctor.
Yeah, I mean, how do you explain this?
They are.
What's the number of your positive predictive value?
It's 20%.
20?
20. It doesn't. I'm sorry, it's not shown on the screen, but it's 20%
It's
because
very low, huh?
Because positive predictive value and negative predictive value are both affected by the prevalence. Since the disease is not that prevalent, it lowers the positive predictive value. The answer to your question.
Okay.
Any more question? Yes, please.
So thank you for your presentation. Very nice.
Wow.
So did you make sure whether the sample was arterial or venous?
It was venous. Sorry?
Umbilical artery or vein sample?
I'm pretty sure it was venous.
So how does this reflect the baby?
I'm not really sure, to be honest. Can you?
Because the venous one comes from the mother, right? From the placenta.
Yes. I'm not really sure it was arterial or venous.
Thank you.
One more questions, please. Yes.
Yes.
Go ahead. Okay.
Professor Jad? Yeah, it's not a question from the speaker, but just a small comment that the quality of presentation by all the speakers was very good. And for the level of their training, they presented very well. And I think they all should be congratulated for their efforts. Thank you.
Thank you, Prof. Sijad, for this nice comment. Actually, you are faster than me. I'm going to say the same comments. Actually, we enjoy 5 talks. Each one, it's addresses a very important subject. Thank you very much for the speaker and also for the delegate. Maybe now Prof. Prof. Khalid Al-Falih has a talk, and then I hope that you will
Prof. Saad, while they are finding, the result, can we start our closing ceremony? We will announce the result of the written.
Actually, we have the result.
موجود عندك تفضل.
We would like to invite you and Dr. Nimri to the
طيب, go ahead. يلا يا عبد الرحمن تعال.
To present the awards. And I think I would like to take this opportunity and to to thank the Saudi Neonatology Society for keeping this tradition of research abstract presentation a regular occurring in every annual meeting of the SNS. And I do hope that in the future we will be able, inshallah, to encourage more and more research in the country. We really highly need more and more of high quality research, epidemiological studies in Saudi Arabia to guide our practice and policy making. Dr. Saad or Prof. Saad was much more generous than I am. So we took the average of the 2 marks that we marked the presentations during the presentation, and we will start by Prof. Nimri. Are you ready? You're ready. Okay. We will start with the 3rd award that was given to Dr. Muhammad Bahadir for his presentation. صوروا. Third, yes. MashaAllah. Make sure I'm in the picture, please. Thank you so much. يعطيك العافية. توفيق إن شاء الله. Our second award for today is given to Dr. Awid Fatani for her excellent presentation. A certificate from the SNS for her award and a 3,000 riyal. Now comes to our winner of 2022 SNS abstract presentation that was given to Dr. Wiam Al-Saidawi from King Faisal Hospital.
مبروك يا وئام. You win 5,000 riyal from the Saudi Neonatal Society. قلنا لهم حطوا زيادة 0 قالوا ما في ممنوع. مبروك يا وئام. بالتوفيق. يعطيك العافية. Also, we have some other people to be appreciated, and we'll start with the podium. We have Dr. Khalid Al-Falih. Khalid Al-Falih, Professor Khalid Al-Falih is one of the people who are quite near to the society. الله يحييك يا مرحبا. يا بروفيسور. الله يحييك طول عمرك. الله صورهم ها. هلا ما. البروفيسور صالح العليان he was the chairman of the society at one stage, and we to appreciate his work with the society for years with a lot of contribution. ليش لا مشكلة لك يا اخي تأمر والله بين تسلموا. شكرا. الله يحفظكم، بارك الله فيكم. طيب بقية الزملاء اللي شاركوا في البحث العلمي نحب أن نعطيهم الشهادات للشكر ونتمنى لهم إن شاء الله التوفيق المرة الجاية. باقي عندنا فيتا بيتر وكذلك سعد العامري أو العامر. تفضل. Middle? Yes. Yeah, you need to be in the middle. Hey, the regulation for things.
Vita. One more. Yes, yeah.
سعد تفضل يا عبد السعد.
المري مش العامري.
المري هو كاتبين المري ها. ونعم حياك الله.
شكرا لمشاركتك.
موفق ان شاء الله. السنه الجايه تجيب لنا انذر تو ريسيرش ان شاء الله. ولازم تفوز. الله يحييك طول عمرك. هلا. تفضل. هنا قاعد الملك فيصل والاستاذ سلمان الغايدي. الشكر موصول لقاعة الملك فيصل والتجهيزات الجميلة اللي موجودة فيها، ونشكر الأستاذ سلمان العتيق، ونحب الحقيقة أن نشكرهم. يعني كانوا حريصين أنه يعني يكون البرنامج إن شاء الله في أفضل حالاته. الله يحييك. الله يحفظك المقدمين مشكورين. الله يحفظك يا هلا ابو فارس. والاستاذ عبد الله الحميدي. ان شاء الله اذا زرتوهم السنه القادمه حيكون عندهم رينوفيشن، حتشوفوا شيء جديد، يعني شيء يعني يجعلكم يعني تنبسطوا اكثر. هي
سكرين تكون موجوده من اول يوم.
وحبيبنا الاستاذ والدكتور مجيد سعيدان، تفضل الله يحفظك.
Was my teacher in 1993.
نأتي فقرة الأخوة المشاركين من الشركات الراعية، ونبدأ بالراعي الذهبي للمؤتمر شركة أسترازينيكا. تفضلوا يا جماعة. حقيقة they commit themselves from early on they continue to commit themselves for the activity of the society, supporting the educational like you know. الأحسان الأحسان حياك الله يا مرحبا. افتح لهم اياه عشان يصورون. هذول الذهب، هذول أخبار الذهب. الله يسلمك. دعواتنا لكم بالتوفيق. التسويق شهادة كمان بعد. تكنو اوربت تفضلوا. مهندس حازم، مهندس فادي، حياكم الله. They are committed يعني with us for the last few years and we would like to continue with this type of. الله يحفظكم. شكرا. الله يحفظكم. بارك الله فيكم. بالتوفيق. شو المناورات هذه؟ شو المناورات يا منبري؟ الله ما شاء الله عليك. شكرا. نبغى ابوت نستلا، تفضلوا. يعطيكم العافية. بعدين نسلة نضيف نوتريشن ولا ما في؟ يلا. ايش اسمه دول؟ لا بعدهم ايش اسمه؟ يعطيكم العافية. اهلا وسهلا. الله يحفظك. موفقين ان شاء الله. أرديسة هم البليمير. ها اوكي. لا الله يحفظك. يا هلا سيدك. هلا يا هلا. يعطيك العافية يا مروان. شكرا. شركة الجيل ما في شيء موجود. الأخوة بمناسبة توقيع الاتفاقية مع جمعية الرضاعة الطبيعية، ودنا أن نكرمهم كذلك بينكم الدكتورة فاطمة الجعوان. تفضلوا. والحقيقة ودنا نكرم كل الأخوة المشاركين في الورك شوب، لكن الحقيقة ما شاء الله عليهم لا زالوا يعني يعملون بجد واجتهاد ويعلمون، فلذلك الظاهر نحن بنروح من يريد أن يحضر تكريمهم فليأتينا هناك، أما نحن فذاهبون حتى نكرمهم يعني في موقعهم، فالله يحفظهم. جزاهم الله خير. وأنا حريصين الحقيقة، وأنا متأكد الأخوة اللي شاركوا في الورك شوب استفادوا كثيرا. دكتورة فاطمة الجعوان، بالتوفيق يا دكتورة. إن شاء الله فاتحة خير إن شاء الله. الله يحفظكم. طيب، وأنا أدعو على الكلمة الأخيرة لرئيس الجمعية.
مش أنا قلت لكم. طيب، السلام عليكم ورحمة الله وبركاته. الحمد لله على التمام، الحمد لله على الكمال. بالأمس وقفت هنا وتتذكروا أول شيء قلته،
اللهم لا سهل إلا ما جعلته سهلا وأنت تجعل الحزن إذا شئت سهلا. فالحمد لله على تسهيل هذا المؤتمر رقم 21. A lot of obstacles لكنكم من أجل عينيكم غنينا، ومن أجل عينيكم أوجدنا لكم أحسن المطربين، فغنوا لكم طوال هذه الثلاث لأنكم تستاهلوا. فوجودكم هو نور المؤتمر، تواجدكم هو نجاح المؤتمر إلى هذه الساعة. أشكركم من أعماق قلبي. الشكر موصول لمدير المؤتمر دكتور عبد الحكيم قطان واللجنة المنظمة وجميع الأعضاء. الشكر موصول لأبو مروان بروفيسور سعد السعدي وهو في اللجنة العلمية. أحضر لكم ماتيريال كلها clinical practice maybe this is the first time to bring our breast milk to bring our breastfeeding in the conference وإن شاء الله will continue. فشاكر لكم من كل قلبي، وأتمنى السنة القادمة مع البورد الجديد لأن يمكن هذا آخر مؤتمر لهذا البورد. امبارح شكرت كل الأفراد وقلت لهم ما عندي شيء غير إن أدعي لكم. أقولها ولا لا؟ فأستودعكم الله وأتمنى أن أشوفكم في 2023 بإذن الله تعالى. شكرا جزيلا سفر. يعطيك العافية. بارك الله فيك. ايوه اليو اس بي حقي باخذ. ايش رايك؟ الله يكرمك طول عمرك، بس نحن عشان ايش؟ بس انا خايف اطلعه ويصير مصيبه يعني. لا الحين يصير له ايش يقول هذا ديفايس is currently in use، فكيف نسكره هذا؟ او انا اقصد حقي هذا. في طريقه ثانيه للتسكير وريني اياها عشان شايف سكرها من هنا صح. بعدين تجي مره ثانيه سكر. حلو. شكرا الله يحفظك. الله يعافيك.